Am I audible now?
Yes, ma'am, you're audible.
Okay. Anita, can you hear some background noise?
Yes, ma'am, I can do that. Just give me a second.
No. I'm talking
No,
about
no.
my background noise.
Oh, okay. Sorry, ma'am. No, ma'am, there is no background noise. Your voice is loud and clear.
background.
Yeah.
Perfect. Okay, because now I'm there at my parents' place because kids would not have allowed me to sit for this long at my own home. So my
Okay.
parents' place happens to be on a highway, so there's a lot of noise, like the horns and other things.
Sure, ma'am. You're clear,
But
ma'am.
then,
You're clear.
yeah, because I've put that noise cancellation, so it should
Okay.
work.
Sure, ma'am.
Okay. All right, I'm putting myself on mute and let me know when we can. Hardly anybody around. It's already 5:30.
Just give me a minute, ma'am. Yeah.
So, Anita, can we start?
So just a second, sir. Just a second, sir.
I'm fine. You can start.
Okay, Dr. Viraj is there. He has to give the introduction in the first place.
So, Dr. Romila, you can call Dr. Viraj, no? So invite him and then you can start.
Okay. Okay.
This cycle is so different from the last year. This massive increase in falls. There was a massive disruption in the economic trajectory.
Anita, I'm not being able to connect with Dr. Viraj.
Ma'am, I'm doing, ma'am. Sir has already joined. We are promoting him, ma'am. Just give me a second.
Yeah, sure. And Saurav, Dr. Saurav Mishra?
Sir is also joining, ma'am. We have informed us, sir is also joining in 2 minutes.
Yeah, sure.
So by the time Master of Ceremony Dr. Romila gets ready, so just I introduce. So with International Association of Oncology, so we have started doing this 3-monthly program. So initial first was after ASCO and this was after ASCO, and thanks to friends like Chandrakant, Saurabh, Soumya, and this time I have taken help of Dr. Biraj because he's one of our medical oncology colleague whose GI is very close to him. So I thought there, so let's put, and this part of the country in Odisha, so we see lots of GI cancers. So with that idea, so we have put the day 1 today of 4 hours for GI and tomorrow Saturday So we'll have head and neck and gynae. So Dr. Biraj is there, so probably
Yeah.
in the car.
Hello, good evening.
Good to see
Good
you.
evening. I'm sorry. I'm sorry. Just reaching
No, no,
home in
it's
10 minutes.
absolutely fine. It's somehow my fault, actually. I should have organized it a little earlier. I suddenly didn't find you in the list of joining. So, good evening, sir. So, should we start
Hi,
now?
good evening.
Are we
I
ready to
think
go?
so. Yeah,
Yeah. Yeah, because we are already late by 4 minutes in
right.
starting.
So, okay. So, good evening, everyone.
Uh, so,
You
just
want
give
me
me
to
a
go
moment.
ahead or you want to? Okay,
Just give me
go
a
ahead.
moment. Yeah. Yeah. A very good evening to all the participants. Myself, as Dr. Ghanshyam Biswas was kind enough to introduce Dr. Romila, the Master of Ceremony for today. A very responsible job, because 4 hours of plenty of discussions. And I take immense pleasure on behalf of the International Association of Oncology webinar series. As sir already told, this is the second of it this year. Today, we are focused on gastrointestinal malignancies. That will be the sessions would be preceded and succeeded by sessions of quiz, and we would throw light on the topics that would definitely add up to our knowledge, and also help in, not exactly help, we would adapt those things eventually in our daily practice. So a heartiest welcome and introduction to our program director, Dr. Viraj Lavigya, from Ahmedabad, our organizing secretary, Sir Dr. Ghanshyam Biswas, and our scientific chairperson, Dr. Saurav Kumar Mishra. So without taking any further time, just a humble request, please speakers, keep a track of the time and let us complete it smoothly and quickly in a smart way. All right. Thank you so much. Over to you, Dr. Viraj. So all over to you now. Thank you.
Thanks, Dr. Romila. So, my name is Viraj Lavingya and I do GI Medical Oncology from Ahmedabad. Greetings, everyone. Thank you, Dr. Biswas, and thank you, Bhuvaneshwar, for having me. It's very nice of you to have me on this program. So today's program is an interesting one. We have about 4 hours of hardcore GI discussions, and today's discussions will be all from the ESMO that happened just a couple of months
Yeah.
ago. So what we have done is there are some ESMO abstracts which speakers will speak, and the moderators will discuss on those abstracts particularly. So, without wasting time, I'm very eager to
Yeah.
learn about the GI. We have covered maximum of GI that was done in this year's ESMO. So, let's go ahead. I think so. We're starting with the quiz first,
Quiz, yeah.
right?
So
Okay.
Dr. Saurav Mishra would take up the quiz, please. He's there with us.
So before Saurav starts, so I'll say, so there are 5 questions. So either 4. So you have to choose one of the best answers or pictorials. And what you have to do, the audience, you have to put the right answer in the chat box. So our volunteers, Anita, Sambit, will just collect the first come first serve who is the right one. And these people who will come first, so they will be awarded a cash prize. So they will be contacted after the meeting and they will be awarded. So right, so here goes Dr. Saurav Mishra from Bhubaneswar with the first quiz master.
Thanks, Ghanshyam bhai. Thanks, Romila. Good to see you both. And thanks, Dr. Viraj, for joining. Hi, Chandrakant, Anita, madam. Hello. So we keep the timer, right? We keep the timer, no? So timer someone will be doing, right? Ghanshyam bhai, that would be there, no? Timer would be there.
Yes, sir. Yes, sir. Quiz timer will be there, sir.
Okay, so let us share the screen then. I have shared the slides text to you, the quiz deck. Yes. So please make it full screen immediately. Yeah. So good evening, everyone. Question number 1. So the prospect trial compared neoadjuvant chemotherapy, radiotherapy with neoadjuvant chemotherapy and selective RT in patients with rectal cancer, which is a false statement. It was a non-inferiority trial design. Clinically, T2, T3, T4, and plus lesions were included. Similar rates of toxicities were seen and the primary endpoint of DFS. Timers now. Please choose the false statement. That means all 3 are correct except 1. Only 1 is a false statement. Rest all are correct statements.
After choosing, we have to tell you. Tell whom or
We have to check the chat box, madam.
okay, we write in the chat box. Okay.
Whatever is the best option.
Okay, okay.
Okay. So we go to the next question. Answers will be at the last. Next question, please. So now, which of the following is true for Claudine 2? That means all three are false. Only one is true. Timer starts now. Thank you. We go to the third question. What does the abbreviation DPD stand for? Time starts now. Thank you. Question number 4. So identify this Indian personality. Which condition was she afflicted with? We have to answer both. Timer starts now. There's no options here. Please, you just have to identify. You have to name it. Yeah, someone started doing it already. Yeah, very good. Interesting answers we are getting actually.
So definitely the hint is a GI cancer, right?
Many of them have gone for lung.
Thank you. Thanks. I think he has hit the bullseye. Last question. Question number 5. So as per Globocan 2020, which is the correct order of the incidence of GI cancers in males? That is in India actually. Yeah, timer starts now. So there is one answer correct here. What is the correct order of among these three malignancies? The incidence according to Globocan, which is the correct thing?
So at the end, Saurabh, so you can go from question 1 to question 5 and tell the answer so that the volunteers can take a record of that.
Okay, great. Thank you everyone for the participation. Now let's go to the answers. Question number 1 was, so the prospect trial. So the answer here is B. So if you remember, the prospect did not include T4 lesions. It was T2, T3, N plus. T4 lesions were excluded. So this is a partially correct answer. Rest all are actually true statements. That means it was a non-inferior design. Similar toxicities were seen with NSCT and all. And primary endpoint was also DFS, which was met. So correct answer here is, the false statement here is B. So those who have answered B as the answer, that is the correct. So who has, so you will declare the answers right now, Ghanshyam, winners? No, that will
No, winners later on, right?
Later on.
So the correct answer
Because
here.
just we'll go through the answers quickly.
Next. So Claudine 18.2. So all are false other than B. So it is a transmembrane protein and it is involved in barrier function. It is not expressed only on gastric tumor tissues. It is expressed very minimally on normal gastric tissues also. Also in other cancers like pancreatic, ovarian cancers and all. Okay. And it's not zolbetuximab, it's Z. So Z. So that is the zolbetuximab. And in the clinical trial, it was detected by IHC testing, immunohistochemistry, rather than FISH. So the true answer here is B. Again, B is the correct answer. Next. So abbreviation of DPD something like a tongue twister. So the correct answer is actually B, dihydropyrimidine dehydrogenase. It's dihydrogenase. Next. And the personality Sanju movie was made on this. I mean, this Manisha Koirala played. She is Nargis Dutt, wife of late Sunil Dutt, and she was affected with pancreatic cancer actually. Last one. And the correct order here is stomach more than colorectum more than esophagus. So C is the correct. So stomach is more than colorectum more than esophagus. So thank you to everyone. And
Thank you.
just to add, so in TMH Mumbai, the ICU is named after Nargis Dutt only. So that is a
Oh,
ICU.
wonderful. That's nice. Not for a good cause though, but good
Yeah.
gesture as
For a
such.
good cause, no, the patient. So it was
In the memory of, yeah,
memory, right?
yeah, good.
Tata
So
Memorial.
thanks.
No, Tata Memorial also.
Right. Ji. So now we quickly proceed towards our session one. That would be moderated by Dr. Vamshi Krishna, medical oncologist from Kolkata. Medical oncologist. Do we have you, sir? Dr. Vamshi is there? I think
Yes,
I saw him.
I'm here. I'm
Yeah,
here.
sure. So over to you, sir. We are actually already late just by 5 minutes. I hope we recover this time. And over to you to conduct the session, sir. Upper GI cancer.
Thank you so. Yeah, thank you so much. So, without any further ado, I'll just go on to the next speaker, Dr. Chandrakant, who will be talking on 2 abstracts. So, we have 4 speakers who will be discussing certain abstracts, and then I'll just have a small panel discussion on the same. So, over to you, Chandrakant.
Thank you, Dr. Vamshi, for that introduction. I would thank Dr. Ghanshyam for the opportunity. So I think I've got 2 of the answers right. Hopefully, I'll be getting that. So I would request the organizers to share the slides. Yes. Can you make it full screen? Yeah, it's full screen. Okay, thank you. So today I'll be quickly presenting 2 important studies of ESMO Keynote 585 and the Matterhorn study. Okay, next slide. So what is this actually? In the non-metastatic adeno-CA of G junction or stomach, in the perioperative setting, chemotherapy is the standard of care. Perioperative chemotherapy is standard of care. We all are aware of how magically changed the outcomes in this setting. 3 ECF surgery, 3 ECF sandwich regimen is what we call. And then we had FLOT. Again, FLOT improved survival, and this is the standard of care. And then came something like a HER-FLOT, where you can actually use anti-HER2 agents along with FLOT that also improve survival. And the median overall survival, what we could attain by all this is around 4 years. What is Keynote 585? It adds to the same regimen 1 year of pembrolizumab, perioperative, postoperative, and maintenance. And the Matterhorn study adds 1 year of durvalumab. So remember, these immunotherapy molecules do not have toxicities, therefore they keep continuing for 1 year for whatever reason. And the conclusion of these studies is both of them improves pathological complete response. It non-statistically improves event-free survival, but does not improve overall survival. Therefore, the conclusion, if someone wants not to listen, the conclusion of these studies is that we cannot use this IO in this space because there is no survival benefit. Okay, next slide. Okay, so this is the first slide of pembrolizumab. Next slide. Yeah, next slide. This is the design of the study. A treatment naive locally advanced gastric gastroesophageal cancers. So here, both the chemotherapy regimens were used. Cis 5FU was used along with pembro, and you can just see they use for 3 cycles, surgery 3 cycles, and then pembro maintenance for up to 1 year. Next slide. FLOT. So they have used cis 5FU and FLOT. Next. So there are 2 parts of the trial. 800 patients, they use cis 5FU as the chemotherapy backbone. In 200 patients, they used FLOT as the chemotherapy backbone. Next. So these are the baseline characteristics. Majority were stage 3 disease, gastric cancers were there, and across the globe, the patients were recruited. Next. Next. So what are the baseline characteristics summary? 75% were stage 3 gastric cancer, and the CPS was more than 1. 80% of them underwent R0 surgery. Next. So this is the complete resection rates, quite interesting. In the FLOT arm, the difference is not much, whereas if you are using cis-5FU, the difference is there, 5% difference in R0 resection if I add pembrolizumab. Next. So what are the results? Pathological complete response, 10% absolute difference, 12 versus 2. And then the event-free survival is 44 versus 25 months. And the overall survival is 60 versus 58 months. So remember, only the pathological complete response was significantly different, whereas the event-free survival, even though numerically good, but it was not statistically significant, and the overall survival was also not statistically significant. Therefore, the important message is the pathological complete response does not translate to overall survival always in gastric cancer. Next slide. This is the pathological complete response difference. Next. This is the subgroups, all of them benefited. Next. This is the event-free survival, even though there is benefit, but it was not statistically significant. The hazard ratio was 0.8. Next. Again, there was numerically good benefit in EFS in the pembro arm. Next. The overall survival was not met. The hazard ratio is 0.9 and it is crossing confidence. So there is no difference in overall survival. Next. Okay, next. So this is the slide that says EFS, OS were not statistically different. Next. So what is the conclusion? Adding pembrolizumab to perioperative chemotherapy improves pathological complete response rate. EFS is promising but not significant. Overall survival, there is no improvement. PCR does not translate to OS. We should learn from metastatic setting where IOs did not do well in all patients, only in CPS more than 10 they did. And we must also have a study in the high PD-L1 subset. For example, in the CPS more than 10% was there a benefit? And secondly, what about HER2 positive subset? Did we have a difference? So these are the flaws of the study. Next. So the similar thing, the Matterhorn is the same perioperative treatment, but in combination with durvalumab. Next. So Matterhorn again is a phase randomized study. 4 FLOT surgery, 4 for standard of care, and durvalumab was combined for up to 1 year. The primary endpoint was event-free survival. Secondary endpoint was pathological complete response and overall survival. Next. This is how the study design looks like. Durva FLOT versus placebo FLOT. Next. Yeah, next. So quite a large study. If you look into the baseline characteristics, 70% of them had T3 node positive gastric cancer. 90% patients had PD-L1 positive. 80% underwent surgery. T2 lymph node dissection was done in 75% of patients. Next. So what are the results? Again, durvalumab addition improved pathological complete response by 12%. However, the event-free survival and overall survival are yet to be reported. Next. So baseline characteristics, I think we already looked into. The majority of them are PD-L1 positive. Next. So this is the pathological complete response difference of 12% delta, 19 versus 7, 22 versus 8. So there is, on adding immunotherapy in perioperative setting, there is definitely increase in pathological complete response, but this has not translated to overall survival in the pembrolizumab study. Next. Yeah. Both complete and near complete response are better. Next. Okay, next. So very important is in the German population, the difference was more than the rest of the patients. Next. So let me draw the conclusions if someone has not listened throughout the presentation. So adding perioperative pembrolizumab and durvalumab to whatever chemotherapy regimen you use in gastric cancer or G-junction cancers does improve a pathological complete response by 10%, which is significant. And number two, pembrolizumab trial did report that there was no difference in event-free survival or overall survival. Durvalumab study, the Matterhorn study, has not reported the event-free or overall survival yet. So we need to, in the metastatic setting, we have seen that immunotherapy like Nivo or Pembro have not shown survival benefit in all patients. They showed only in CPS more than 5 or CPS more than 10. Hence, in the adjuvant setting also, we need to study the benefit of these agents in the subset where the PD-L1 is high. At present, immunotherapy should not be recommended in the non-metastatic adenocarcinoma of stomach or gastroesophageal junction. Thank you. Thanks all of you for patient listening.
Thank you for that crisp and wonderful description in a very simple and comprehensive way. Dr. Vamshi, are you there around, sir? The next
Yes, I'm
talk
there.
is, yeah, sure. So
No, you
the
go ahead,
next
please.
speaker,
Please,
yeah.
you can go ahead and introduce the next speaker. It's fine.
Yeah.
I think this there's no point in shuffling between the two of us. It's fine. Please go ahead.
Sure. So I would now request Dr. Sumit Goel, medical oncologist from Delhi, to kindly present his topic, duplet versus triplet in advanced G cancer. So are you there with us? Yeah.
Yes. Good evening, everyone. I'm
Good
there.
evening.
Can someone play my slides from there?
Yes, sir, I'm sharing it.
Yes. Okay. So good evening, everyone. Thanks, Dr. Ghanshyam and Oncology Updates for giving us this opportunity today to interact and discuss. So the topic that has been allotted to me is the doublet versus the triplet in advanced gastroesophageal cancer. So I'm supposed to speak on these two topics. One is GasFox studies, which is Protege 51 study, and the other one is V325 study, which was the old
I replied
study,
in core groups.
which had compared doublet versus triplet. So the first study is the GasFox study. So it compared 5-fluorouracil and oxaliplatin plus minus docetaxel in the first-line treatment of HER2 negative, locally advanced or unresectable or metastatic gastric or gastroesophageal junction adenocarcinomas. It was a phase 3 study. Next slide, please. So next slide, please. So if we come to the background, we know first-line chemotherapy for unresectable, advanced or metastatic GE junction adenocarcinoma. Usually we prefer doublet. So it is either combination of 5-FU or capecitabine along with the platinum. The choice between cisplatin and oxaliplatin, most of us we prefer FOLFOX regime. The triplet plot we know is there in the resectable setting, and it has shown great promise in phase 2 studies. So this study basically assessed the efficacy and safety of a modified plot regime, that is TFOX, as first line in unresectable, locally advanced or metastatic gastroesophageal junction cancers. So next slide, please. So this was 1-to-1 randomized phase 3 study, which randomized previously untreated, locally advanced, the same set of patients. The patients, basically, they were PS 0 to 1, they were all HER2 negative. And if they were treated in adjuvant setting, they were all docetaxel naive. So they were randomized to doublet of FOLFOX versus either modified FLOT or TFOX. So difference between TFOX and FLOT is FLOT, the 5FU infusion time was 24 hours, whereas in TFOX it was the same, but the infusion of 5FU was 46 hours. So again, the stratification was done based on PS, the prior adjuvant or neoadjuvant treatment, the tumor stage and location, and pathological subtype. So they had done the PFS and OS analysis in June, and the median follow-up at that point of time was 42.8 months. Next slide, please. So next slide, please. So basically, this is the study. This we have already discussed, that the difference between the different protocols. The docetaxel was there in the triplet, and the infusion of 5FU was different in TFOX versus FLOT. Next slide, please. So the primary endpoint of the study was progression-free survival in the intent to treat people, and the secondary endpoint was PFS per protocol patients, and the overall survival in per protocol and intent to treat patients. And they also looked at safety, objective response rates, and quality of life. So next slide, please. So they had randomized 506 patients, but ultimately in the intent to treatment patients, but per protocol, approximately 225 patients were there in the doublet arm and 228 patients were there in the triplet arm. So next slide, please. So again, if we look at the baseline characteristics between the two arms, it was well matched, minor differences here and there. Majority of the patient in both the arms were metastatic. And again, the signet cell histology was there in 88% of the patient in the doublet and 89% in the triplet regime. And again, well matched for number of organs and sites, and prior adjuvant treatment, neoadjuvant, there was more number was there in FOLFOX regime patients. Next slide. So if we come to the tumor response and analysis, so in the evaluable patients, the overall response rates definitely were higher in the patients who were getting the triplet, where the dosi was added. And the p-value was significant, the 66.2% versus 57.5%. And if we look at CR rates, which was exceptionally high, about 8.1% in doublet and 6.7% in the triplet arm. But if we look at the overall disease control rate, it was higher in the triplet regime as compared to the doublet, 92.4% versus 83%. But again, the stable disease and the partial responses were more in the triplet regime. So next slide, please. So if we look at the PFS again, the median PFS was 7.59 months versus 5.98 months in the doublet arm. And the restricted mean survival time at 12 months was higher in the triplet arm. Again, PA value was 0.007. So next slide, please. So if we look at PFS, again, PFS was better in the triplet arm as compared to the doublet with significant P value. So again, if we come to the next slide, overall survival. So overall survival, if we look at that, definitely showed a benefit in the triplet arm as compared to the doublet, which was 15.08 months versus 12.65, hazard ratio of 0.82 favoring the triplet arm, and significant p-value. So overall survival, if we look at in the per protocol patient, that was the intent to treat. So again, here it was little better in both the arms, and hazard ratio of 0.76 as compared to 0.82. So if we look at the subgroup analysis, majority, the lines are crossing the unity, but important is the PS is good in the intended ITT patients. It was favoring the triplet regime. So the subset analysis seems to be favoring the triplet arm in the majority of the patients. So next, if we talk about the benefit, we do talk about the toxicities. The next slide, please. The next slide, please. The toxicity slide, please. The next slide, please. Yes. If we talk about the benefits, we talk we discuss about the toxicity also. We can clearly see that there were responses which were more. There was PFS and OS advantage in the triplet regime, but it came at a cost. Definitely, grade 4 toxicity, that febrile neutropenia, was there in 20% of the patient, which was about the double of that of the doublet. Again, there was more the number of patients who had more grade 3, grade 4 neuropathy as compared to the doublet arm. Again, the fatigue and the other toxicities were there. So the improvement came at the cost of toxicities. So next slide, please. If you look at the health related quality of life, though the patients had shown a better quality of life index as compared to the doublet, we could see here in the arms clearly separating. So next slide, please. So conclusions of this study was that the fluor or TFOX demonstrated statistically significant and clinically meaningful improvement in PFS and OS and overall response rates versus the doublet in patients who were HER2 negative and they were gastric and GE junction adenocarcinoma. So we know the safety profile of TFOX and mFLOT was manageable and better time to deterioration of the quality of life index was maintained in the patients with triplet as compared to doublet. So it can be considered, so this study concluded that it can be considered as new first-line treatment option for patients eligible for a triplet regime, at least very clearly patients eligible, at least for patients with PDL1 and Claudin 18.2 negative tumors. Next step, maybe in coming days, we may try to combine and permutate by adding the IO drugs with this. So coming to the second study, which is V325.
Just a second, sir. I'm sharing this slide.
Dr. Sumit would request you to be a little faster
Louder,
because we are
closer.
having a time shortage.
Yeah, I'll just finish in my 3 slides, 4 slides. Just so basically, this was the old study which was done in 2006 in JCO. It was published. So this is there, which showed the doses cis and 5 combination was there as compared to cis 5FU. The next slide, please. The next slide, please. Again, it was well matched. The next slide, please. Let's come to the yes. If we see the time to the tumor progression and overall survival. So this study in 2006, again, doses cis-5FU showed there was benefit as compared to cis-5FU alone in terms of both time to tumor progression and overall survival, favoring the triplet regime. Next slide, please. So same thing again, the benefit was there with the triplet. The next slide, please. On the next slide, please. So next slide, please. So basically the crux is that the triplets were better as compared to the doublets, but they came at the cost. But this study done long back, it had poor prognostic patients. The newer study, the TFOX versus FOLFOX, it had approximately 80% of the patients who were metastatic. Here, almost 97% of the patients were metastatic. So the conclusions of these two studies are triplet is an option, but we need to choose our patients very wisely and carefully. With these words, I'll stop here.
Thank you. Thank you, Dr. Sumit. Go ahead, sir. Can I please quickly call upon our next speaker, Dr. Satish, medical oncologist from Bengaluru. Bengaluru has been on news since afternoon after the school evacuation. I hope everything's safe and fine over there with the kids and the families.
Yeah, good evening. Is it
Yeah,
possible
good
to, can I share, like, are you going to, yeah, 1 minute. Is it my slides are visible and I'm audible?
Yes, sir, you are audible and the slides are also visible.
Yeah, good evening, everyone. Thanks for organizer to giving me opportunity to speak here, and a special thanks to Dr. Ganesham. I'm going to present on the one of the abstract presented in ESMO 2023. It is a study of stomach cancer progressed on ramucirumab based treatment. Continuation of ramucirumab and adding to the next line of chemotherapy, is it beneficial or not? That's what is the study is looking for. Uh, as we know that ramucirumab is a fully human monoclonal antibody, targets VEGF. We have a grade 3 like the phase 3 like two studies are there, regard and rainbow study. The second line they have shown that with or without paclitaxel, they shown that ramucirumab showing the beneficial in the second line treatment in advanced gastric cancer. Here like they want to see that continuation of anti-angiogenic drug, like how we do in colorectal cancer or even breast cancer, continuation of trastuzumab and changing cytotoxic drug is try to have a pushing for some more disease control, and like similar in the colorectal cancer, does it go to benefit in this setting or not? That's what they wanted, they tested here. The post hoc analysis is a rainfall trial in a first line advanced gastric cancer. Ramucirumab was continued post discontinuation as a second line associated with try to have a higher survival. Based on this one, this study was designed. That is a Rindberg study. It is having almost 402 patients, and those are recurrent G junction of gastric cancer, refractory to ramucirumab or a first line like taxane and fluoropyridine was used. Platinum-based treatment, good performance status, and age is more than 20 years. And one arm is the ramucirumab continuation. Previously, they have progressed on ramucirumab based treatment, and continuing one arm is the that ramucirumab based treatment with irinotecan versus irinotecan. Here, dose they use is a 150 mg per meter square. They used in primary endpoint is OS and second endpoint is PFS and time to treatment failure and safety analysis. That's what they analyze in this study. You can see that both the arms like ramucirumab plus irinotecan versus irinotecan, they're well matched like regarding the that site the previous treatment HER2 status. There is no much great difference between them. Coming to the endpoint of the study, overall survival rate, like it is showing the improvement in the OS, that is 9.4 months versus 8 months. We don't see that very suppression graphs how you see in other cancer, lung cancer and breast cancer, all those things. Let's like improvement in the increment is like the hazard ratio, adjusted hazard ratio for this one is a 0.91. It's like not statistically significant, but that is showing the improvement trend in the OS. Coming to the second endpoint as a PFS, that is a median PFS is 3.8 versus a 2.8 month. Hazard ratio is 0.72. It is like p-value is significant. It's showing that it is showing that disease control like, by continuing that ramucirumab along with the changing cytotoxic drug is going to be meaningful. Coming to the response rate, partial response and even the stable disease shows to a higher number by continuation of ramucirumab along with the cytotoxic drug. Overall response rate 22 versus 15%. Overall disease control 60, almost 66 versus 53%. Can show that there is a improvement in the response rate with the continuation of ramucirumab along with the change in the cytotoxic drugs. Coming to the subgroup analysis, does it go to benefit in everyone? No. Yeah, majority they got benefited, but should remember it is not like number is 200 in each arm. Like HER2 negative, they not got benefited. Those are not the gastrectomy patients, and those are gastric patients. G junction they got benefited, and prior exposure of ramucirumab more than 3 months, they're not showing that much benefit. This one they try to analyze in a subgroup analysis, but does it make it the salt in this like definitely overall the PFS has shown benefit. Overall surrogate is like try to have improvement in the incremental the rate is without statistical significance. Coming to the toxicity, we are all will aware with managing the anti-angiogenic drug. It is showing the that implementing that standard toxicity of ramucirumab, that is the borderline increase in the hypertension, like that slight increment in the cytopenia. They're all manageable, not without slight increase in incidence of that thrombosis. Coming to the post discontinuation treatment, does it like is there anything? Does it make that post the failure to this one? Does it make any improvement? You can see here those are progressed on this ramucirumab followed by cytotoxic versus the irinotecan based treatment. They're treated with a durvalumab treatment, some reuse of platinum, irinotecan based and ramucirumab. All the things, various drugs are they used. Conclusion from this study, Renberg study, it is a first like it is to report that phase 3 study to evaluate sustainable anti-angiogenic drug in therapy in advanced gastric cancer. how we used to use in the colorectal cancer. It is trying to have meaningful, trying to have control improvement of PFS. And after the failure to the previous the treatment, the taxane and fluorophylline and platinum-based treatment. In addition of ramucirumab to irinotecan, after the progression to the ramucirumab, even though did not achieve the primary endpoint of OS, it definitely showed the PFS, the disease control rate, and overall response was observed. Toxicity were meaningful, and further analysis has to require to understand this like continuation, and is there anything adding like HER2 positive is there, and PD-L1 positive there, like by adding that, does it make any like subgroup analysis, specific group of patient can be analyzed? I'll stop here. Any questions we can discuss? I think we are going to have the panel discussion soon. Thank you.
Thank you. Thank you, Dr. Satish. Can I request Dr. Vamshi to please take up the panel discussion?
Yeah, good
do
evening,
we have
everyone.
our
And
panelists?
yeah, thank you for having me. Thank you, Dr. Ghanshyam. And I think thank you, Viraj, as well, for giving this opportunity. I will call upon the panelists, Dr. Amit Kumar, medical oncologist. Dr. Amit, are you there?
Yes, sir. Yeah.
Okay, great. Dr. Nitesh, surgical oncologist. Dr. Nitesh, I hope you're there.
Yes, I'm there.
Okay, perfect. Dr. Anita, ma'am, I saw you joining. Madam, are you there? Dr. Anita? Okay, I cannot hear her. Could the organizers please ask her to join if she's there around? Dr. Somen? Dr. Somen Roy, are you there?
Yeah, can you hear me?
Yeah, ma'am, I can hear you now.
Yeah. Just if they want, they can put
okay,
it on also.
Sure, ma'am. Okay. Dr. Somen?
Yes.
Yeah, and Dr. Sushanta?
Yeah, thank you. Welcome.
Excellent. So what I'll do is we have 3 medical oncologists and 2 surgeons. So it's a good mix. On a lighter note, I think it's nice that everyone now knows that there's not much role for radiation in stomach cancer. There's no radiation oncologist in my panel for once. So let's move on with the topic. If you could start sharing my screen, please. What we will do is we will have a discussion on the general management of how we treat initial early and localized gastric cancer, and then we'll have a few slides on the metastatic gastric cancer, especially keeping in view already these abstracts discussed. I will do it in 25 minutes. It's now 6:16 in my clock, so we shall close by 6:33, 6:34. I request the organizer to just let me know 2 minutes before I'm supposed to stop so I can wind up. Next slide, please. So the first question is really, how do we define these gastric cancers? Next slide. So let me start off with the medical oncologist, because this is where occasionally we have trouble in agreeing with our surgical colleagues. Dr. Amit, how do you define early, localized, and locally advanced?
So to go with the early, if it is the disease is only localized, is only limited to the gastric, to the stomach only, without any, I'll say it's limited to T2 disease. We are saying
T2. So you're saying T2. And how do you manage to do this staging? Do you do an EUS for patients, or is it based on the CT scan and imaging?
So surely EUS is advised, but for clinical practice, we are only doing CT scan most of the patients.
CT scan. Excellent. Yeah. Dr. Nitish, would you agree with this definition? Early is T2 and anything above T2 would be a localized or a locally advanced. How do you define in your practice?
Yes, sir, I would agree to him. Usually T1, T2, N0, I would say it would be an early gastric cancer.
Okay.
T3 or an N plus disease would qualify for more than an early gastric cancer.
Okay. Wonderful. You have raised a nice point. More than an early. So what is this locally advanced? We get these patients from surgeons saying that, oh, it's a locally advanced, give some chemo and reduce it. Oh, it's localized, I'm going to operate it. How do you differentiate between these two?
Okay, we divide gastric cancers for all practical purposes into, I believe, distal and proximal gastric cancers. Proximal gastric cancers, most of the patients who come to us are usually have N plus disease or T3 disease. Almost all of them go for perioperative or neoadjuvant chemotherapy. and then we end up doing a total gastrectomy or a gastroesophagectomy. For distal gastric cancers, what we practice in our institute, most of the patients who, again, most of the patients who present with gastric outlet obstruction would go for first surgery. Anyone who doesn't have gastric outlet obstruction and has an operable disease, fat plane, again, up to T3 or N1 disease, we can go for surgery.
Okay.
Anything more than that, we subject the patient to NICT.
Perfect. Next slide, please. Dr. Somen Roy, what do you think? Do you agree with this definition? And more importantly, what Dr. Nitish was talking, if it's localized or an N+, I would give neoadjuvant or perioperative. If it is kind of locally advanced, you would go for neoadjuvant. Otherwise, you can even operate if it is distal. Do you agree with that?
Yeah, I agree with Dr. Nitish and everybody, but just I have one contradiction about the early. Basically, it is not my contradiction about all the whatever data and everybody speaking out from Westerns. But the Japanese and the Koreans, where they have the larger numbers and they have the screening modalities, and US modality, they have come up with the early T1, T1A and B. So it is not a gross in management change, but in view of prognostic wise and the lymph node metastasis, they have categorized early up to T1. Some cases there are debates and going on studies about but localization.
Fair enough. So T1, essentially T1, you can also do an ESD. That's basically the discussion. So you can do with the TSD, ESD, you need to go for a surgery. I guess that's what you're trying to make
ESD for gastroenterologists, so they divide and classify into early.
Fair enough. Excellent. And Dr. Anita, fair enough. Dr. Anita, your definition of this division, would you say, where would you say we would give NACT or a perioperative treatment? And is there anything other than early, just T1, T2? Any node positive or T3+, would you say all of them should go for perioperative or any of them can go for early surgery?
Yeah, you see, again, it is an observer variant or a surgical oncology variant, definitely. So some in higher centers with a gastric major institute with huge volume, many of the diseases are operable. So they do operate even on a little more stage. But then in centers where the expertise is not so much, then the definition of early becomes different, and you get more cases. You give the chemo and then send to us. So that is the gray area. Yes, sometimes node 1s can be included. Sometimes they may not include the node 1 disease also. So again, I take it that way. We leave it to the surgeons in whichever hospital, and that early disease, they take it.
So you're a good surgeon's friend. You leave it to the surgeons to decide what they want to operate and what they send to you for neoadjuvant. Very good.
Yeah.
Dr. Susanta Kumar, your thoughts on this?
Come to us.
Dr. Susanta, you're there?
Yeah,
okay,
yeah.
Next slide, please. No, again, the reason why I keep bringing this discussion on NACT is, for medical oncology community, it's almost an article of faith. Anything beyond T2, T3, N+, you have to give perioperative.
Yes.
But a lot of Asian guidelines, including the Koreans and Japanese, who actually have a big fan following among all our surgeons, and they're not wrong. They believe that everything should go for surgery upfront and then go for a kind of a adjuvant therapy. And they say there's no difference in OS. You don't have very good data, honestly, to say that perioperative is much, much superior to a adjuvant setting. Dr. Anita, would you agree with that? Or do you think that, the data that we have from the FLOT AIG and all will actually be good enough to say everyone should go for perioperative?
Yes, then I also feel that now we are slowly moving, like in breast, we have started giving all the neoadjuvant chemotherapy and then we hand it over to the surgeons. I think gastric cancer, this may be another area, give the chemotherapy and then do the surgery. So yes, neo is more. And now with the, not so much proven, we have targeted drugs also creeping into the armament area.
We will talk of targeted after this. I'm not sure whether I agree with you on this, but we will talk about this. Dr. Nitish, your comment on this. Do you think that except those areas you said which have gone into, say, surrounding structures, or it is infiltrating the surrounding structures, where definitely those are bad diseases? Chemo doesn't do much in those cases. But other than that, should everyone go for a surgery upfront, or are you convinced with the perioperative data? And if so, why are you? What is the NACT going to do in a benefit to you, Dr. Nitish?
We go for surgery only in very early cases, which are rarity in our setup. For distal
So you believe
cancers,
in the perioperative?
Yes, we do.
So you believe in the perioperative? Okay, perfect. So I think our panel is full of friends. Dr. Anita wants to leave us into surgeons, and Dr. Nitish says, let's do neoadjuvant for everybody. Excellent. Next slide. So coming to this presentation, I think the panel seems to believe and agree that possibly NACT seems to be a standard of care, and most patients should get NACT, especially T3 and N+. I think that's a fair summation. So Dr. Sushanta, if you have joined us. Okay, Dr. Sushanta has not joined us yet. Okay.
Am I audible?
Yeah, you're audible, Dr. Sushant. So I was just
Yeah,
discussing about the role of NACT, and do we agree that NACT is kind of like the standard of care now for all gastric cancers?
Definitely. If I think
Definitely.
any T3 case and T2 also, if team of the doctors that in tumor board is agree, we can go ahead with the NACT followed by surgery.
So why NACT? What do you achieve with NACT? I mean, what is the benefit you're getting with NACT?
One thing is we know that if you go into the trial data, it will give us if the response is pathological CR, they have a good.
It's around 5%. The flawed data of CR rate is around 5 to 7%.
I mean that if it is NACT, then we should give them to flawed only, not the pulpox in NACT
No,
setting.
I'm okay with flawed. I'm telling you the data of flawed. The flawed has a CR rate of around 5 to 7%. We're talking CR. Good response as in TRG1 or something, possibly 15 to 20%. We are not seeing the breast kind of responses. We are not even seeing the lung responses of 17, 18%. We are seeing 5 to 8%. So that's the reason I'm asking, what is the intention of giving? I'm being a devil's advocate here. I'm a medical oncologist. I love giving flawed because I find that post-op, the nodes are less. So I'm happy to downstage it. But pathological CR really doesn't happen much in stomach. That's my feeling.
We saw that if there is no response, sometime we gave flawed, but there is no response at all. These patients have relapsed within 6 months of surgery. So the response is much required.
All right, fair enough. So again, for the purpose of today's panel, let's, I think, agree that NACT seems to be a standard of care, but I take the point of any of the surgeons who would argue that if it's small nodes, you're not wrong in actually doing a surgery upfront. The Korean and Japanese guidelines do follow that. In fact, the updated ESMO guidelines, ESMO guidelines also do the same thing, ESMO Asia. Most of the perioperative data has come from the West and from the Americans. So that's the way it is. Next slide. So this was the first paper that was presented about pembro plus chemo versus chemotherapy, and they showed that it showed a improvement. Now, interestingly, the idea is that the trial of the perioperative chemotherapy was between 2 cycles of perioperative chemotherapy. You do not have a very strong evidence. You do have some Korean trials on it, but not very strong phase 3 data which says that perioperative is better than pure adjuvant. Next slide. Now, coming to this study, that is the Keynote 6585, what they did was use these patients T3 and above. They gave pembro plus ciscapstabine or CAPE5FU. Okay. Now, everyone in the panel has said that we wanted to give flawed. This study has used CAPE-CIS and CIS5FU. Next slide. So, for me, this is a big issue. How can you have a comparator arm with CIS5FU and then say additional only 200 patients with flawed? Dr. Amit, are you comfortable with such a study which actually looks at 400 patients without flawed, 200 with flawed, and then compares and says, yeah, it's doing fine? What's your take on that?
So that's definitely a limitation of this study, I'll say. The standard of care has been changed to flawed. Most of the cases we are using flawed, and they have put it in maximum 300 patients on the XP arm and 200. Other 200 and 100.
Correct.
So I think so that's flawed this study, and that's why the results are also very much different. And the other thing is that CR is still, I'll say, it's not an absolute marker. Even in this study, we have both seen an improved PAT CR, but it hasn't translated to OS anyhow.
Perfect. Dr. Somen, your thought on this? The medical oncologist in your place will say, okay, look, I'll give FLOT and I'll give you CR, PAT CR. Are you happy with that, or do you think it's more to do with how the entire disease is? Dr. Somen.
Yeah. See, I've seen also patients after FLOT complete pathologic response. But whatever the medical oncologist FLOT or somebody gives a FOLFOX therapy, if the disease location is important, antropyloric or it is in the proximal setup, it depends. For a surgeon point of view, it matters.
Okay, great. Next slide. Can I have the next slide, please? Yeah. So the other thing was this. I mean, Dr. Amit or Dr. Sushanta, Dr. Anita madam, you're a medical oncologist for so years. Can you interpret this? I mean, just look at the kind of hierarchical testing they have done. If this is there, then this. If this is there, then this. And finally, what we are seeing is the third interim analysis. The final is not yet there. So what are your thoughts on this kind of a statistical design? Dr. Anita?
Statistical jugglery. It's difficult to understand.
Yeah. And somehow with more and more of immunotherapy trials, you kind of end up seeing more and more of these. You know, p-value of 0.035, 0.008. It's very confusing. Anyways, this is what they have done. Next slide. Now, this is the details of both of them. And as I was telling the panel, the PATSIA rate for only FLOT is 2.5% or 10% or 3%. And it goes up to 12%. So you're seeing a 10% increase in the FLOT in the PATSIA, but 10 to 12% is good, but does that actually translate into overall survival? Now, for me, more importantly, look at the MSI, 9% MSI. I know that's where my immuno is going to possibly work in, but it's only 9%. Look at the tumor location, 10, 90, 80% are stomach, 20 are GJ. Again, you're mixing up two different things. So I'm not sure how good this is. Next slide. And of course, what Dr. Amit has shown that...
Sorry to interrupt, sir. 2 more minutes. Sorry.
2 more minutes? Okay, perfect. Next slide. So what I wanted to show is, since I have only 2 more minutes, that despite adding pembrolizumab to the chemotherapy, now this is the Matterhorn. Now Matterhorn looked at something doing similar with durvalumab. No confusion, they used only FLOT. Here, however, the FLOT did perform better. It gave 6 to 7%. With durvalumab, it went up to 16%. Again, you're only looking at PATSIA. We don't have the EFS or the POS data in the Matterhorn. Next slide. When you looked at the KN585, this is the Dante study, which was using atezolizumab. Next slide. Again, it shows you a PATSIA of around 10 to 12%. Next slide. So ultimately, though you're increasing your PATSIA with the use of immunotherapy, not really sure that in any way it is impacting the EFS or the OS. So next slide. So last questions to my panelist, Dr. Anita. Do you think immunotherapy is ready for NACT in G junction or in stomach? Is this improvement in PATSIA enough for you, or do you want to wait for OS? Last part, would you also say that, okay, let's do only in PDL1 high or an MSI high? Dr. Anita.
The results that was presented in this is not very encouraging. But that doesn't mean that we have to leave the immunotherapy. We need to do a better subset of patients with high good PDL score and tumor mutational burden better, and see what the results are there. And then we will take. Definitely, all these studies at presented here does not support immunotherapy.
Okay. Dr. Amit, your thought, next MDT, are you going to push for giving?
No, so it will be definitely an option, but it, to be frankly using in all patients, not at all. Still, we are searching for a better biomarker to keep it in the place.
Perfect. Dr. Nitish, your medical oncologist will ask you to go for immunotherapy. Would you agree, or would you say, show me the data, show me the OS?
Definitely there is, I would like to wait for the OS data to come before starting with immunotherapy in the neoadjuvant setting.
Perfect. I think more or less everyone would agree. It is interesting data, not final data. Next slide. I will just take 1 more minute and then I'll close. Next slide. Right. This was the data on the GastFox, basically using FLOT or FLOT-FOX versus FOLFOX in metastatic. Next slide. The benefit here, if you looked at the followed the data, was only 1 month of a PFS. Next slide. Now, typically we do use only a KPOX or a FOLFOX. And again, next slide. The additional benefit of immunotherapy is only in those who are PD-L1 positive. So again, in India, I think this trial is useful for us in India because we do not have data with, we do not have use of immuno for more than 90% of our patients. So I think in this situation, what GasFox tells us is that if you have a patient who is having early disease, who is a very fit patient, who is young, possibly to increase your EFS, you can use this kind of a therapy. But will it actually translate into a big OS advantage? Are you getting a tail of the curve that you get with immuno? And the answer is really no for that. Next slide. Next slide. Again, next slide. So FLOT has issues in India, but again, in a good center, most of us are able to use it. I will not talk much about the Rindberg study. The Rindberg was pretty much a negative study. Ramucirumab is still there in gastric cancer. We do use it in second line, but sequencing is the challenge. And frankly, using more and more of Ramucirumab in gastric cancer in earlier lines or later lines seems to be like flogging a dead horse one. So I thank all my panelists. If anyone has any other comment, otherwise we will close and hand over to the organizers. Yeah, you can close the slide set. There are a few slides which I have not used. So, yeah, over to the organizers. I'm done.
Thank you, Dr. Vamshi. It was definitely very informative and fruitful as well for this lovely discussion. We quickly move towards session 2, focusing on the molecular part of the GI malignancies. I would hand it over to Dr. Viraj, sir. Kindly take it up. Thank you.
Good evening. So moving on to localized colorectal cancers and neuroendocrine, we have two presentations, one by Dr. Shefali. She will present the data of Pegasus. It's on liquid biopsy for stage 2 and mainly for stage 3 colon cancer. And later on, I'll talk about neuroendocrine. So Shefali, if you're there, please go ahead.
I think she's there. Yeah. Hello, Dr. Shefali.
Okay. Yeah, good evening.
Long time.
Let me share the screen or yeah. Good evening. So you can share the screen or should I?
Sharing your screen.
The organizers, yeah. Anita, please come.
Okay. Yes, please. Sorry. Yes, very good evening, everyone. And I'll be presenting this Pegasus trial. This is post-surgical liquid biopsy guided treatment of stage 3 and high-risk stage 2 colon cancer patients. Very interesting trial. Next slide, please. So there is much say in this is a conflict of interest and disclosure by the study authors. Next slide. And the background, we know that it's much talk about that what is the role of ctDNA in adjuvant setting, that too in stage 2 disease particularly. And we discussed, heard about Natera finding that if somebody is ctDNA positive in such a setting, that there is a 100% recurrence rate. But would it mean that escalation of chemotherapy in this setting would help or not? So trials going on, and Pegasus is one such thing which gives us some insight. It was a feasibility study, so it gives us insight and thought about the escalation of treatment. But it's too early to conclude anything on this. So it says that cell-free tumor DNA status negative versus positive is an expression of MRD, and it demonstrates the ability to identify the subgroups of patients with different prognosis. So whether to treat them on the same ground or in a different manner, let's try to see. The next slide, please. So the aim of the trials were actually assessing the feasibility of using liquid biopsy to modulate adjuvant treatment based on post-surgical ctDNA absence or presence, and to mitigate the risk of ctDNA false negatives. That is why they double-checked with a double liquid biopsy to avoid patients under treatment, and to explore the feasibility and potential benefit of treatment escalation in patients with ctDNA positive after the adjuvant chemotherapy. Next slide. The study design was such that first we staged the patient as per the radical surgery into stage 2 high risk. They included T4N0 MSS, and stage 3 patient, that is up to N1 disease, T2 or T3. And then they perform the liquid biopsy. The patients with the ctDNA positive in this setting tend to receive K-pox for 3 months, and ctDNA negative received CAPE adjuvant setting for 6 months. Next slide. And the post-adjuvant phase, they again did the liquid biopsy. If it was still ctDNA positive in the Capox arm, so they escalated to FOLFIRI. And if it was liquid biopsy negative, they de-escalated to capecitabine, and they continued it. And repeated time intervals liquid biopsy were performed, as you can see in the slide. And the patients who were on adjuvant CAPE, after the adjuvant completion of 6 months, they did the liquid biopsy, see the ctDNA. If it is positive, again escalation to Capox, and if it is negative, then the stop treatment there and monitoring by the liquid biopsy. Next slide, please. So the primary endpoint was, of course, number one, to avoid the false negative cases. That is why after one cycle of changing the treatment or changing the setting, they checked the liquid biopsy again, and the secondary endpoints were DFS at 2 and 3 years, overall survival at 5 years, and rate of patients seroconverted. So we saw in the last slide that there was a provision that after completion of adjuvant, who were initially liquid biopsy negative, if they recurred or ctDNA positive, what should be the line of treatment, and if ctDNA positive becomes ctDNA negative, then should we de-escalate? And
Sorry,
of course,
2
the
minutes
safety
more,
and
ma'am. Sorry.
okay,
2
okay,
minutes.
all right. So the main idea of the trial is limited to these 2 slides. Next slide, please. So we'll see what happens. Statistical plan I would not discuss. Come to the next slide. We'll see what were the conclusion of that. Okay, so this was the study enrollment and population. So overall, what I see is 135 patients were enrolled per protocol assessment. Next slide. And this was the stage and MRD detection rate as per the liquid biopsy. Next slide. And this, in out of all patients, ctDNA positive were found to be 26% and negative were remaining. Next slide. In this high risk group. And in the low risk patients, as per liquid biopsy, 21% were upstage. In all of the patients, when they tested, the ctDNA was positive in 26% of the patients. And then amongst those, the high risk patients, they were 32% were ctDNA positive, and amongst the low risk clinically, they were 21% positive. Next
Ma'am,
slide.
30 more seconds. Yeah. Sorry.
You are running too fast.
I'm
All
very
right.
sorry.
So come to the conclusion slide then. So at least people should carry on the message, see the message what was there. Okay. Come to the conclusion slide, because 30 seconds में ये सब नहीं discuss कर पाएंगे. All right. No. इतना हाँ. पीछे हाँ.
Yeah.
पीछे और पीछे थोड़ा सा. Yeah. So this actually feasibility trial suggested that MRD rate, number one, was similar to retrospective and prospective studies, and there is a prognostic strong effect of ctDNA is confirmed in this population. So what do they mean is highlighting the results from Natera. So we can select from the ctDNA studies that which patient need a de-escalation or which patient need a escalation. But whether this escalation or de-escalation is fruitful in the long term, we still need to see. So at a median follow-up in liquid biopsy of 21.2 months, 10 false negatives have been observed. And for definitive conclusion, at least 24 months minimum follow-up is needed. Seroconversion of MRD positive patients at the end of any treatment is 40%. So 40% who were MRD positive can turn into MRD negative if we escalate the treatment. And site-specific ctDNA detection in clinical relapses suggests lower accuracy of the test in local lung and peritoneal disease MRD. So I think what my take on this trial is, of course, this needs a further study. This is very important area because the relapse rate in stage 2 high risk is almost to the tune of 5 to 7%, and it is more, that is 10 to 12% in early stage 3. So many of the patients, the studies have shown that we can spare almost 15 to 20% of the patients from aggressive chemotherapy if we can utilize this information over a span of long-term trials to see whether that de-escalation or escalation can help in a meaningful survival outcome. So thank you so much. I could conclude in 2 minutes this much only.
No, sorry to run
Yeah.
you through, but then thank you. It was informative and
It's okay. That's
Dr.
okay.
Virat.
Well, thank you.
Yeah, thanks, Shefali. I would appreciate if you can stick because I have a case on stage 3 escalating, so you can further discuss Pegasus there. So
Sure.
next talk is for neuroendocrine tumors, and after a long while, I think so 5 years I can remind back, that there were no new phase 3 studies on neuroendocrine for medical oncologists. Finally, we have 2 cabozantinib trials, and importantly, because we have generic cabozantinib available here. So to discuss those 2 abstracts, I would call Dr. Krupa Shankar. Hi, you are there?
Hi, Viraj. Good to hear
Hi.
from you, mate.
Great. So please go ahead.
Sure. Thank you, Viraj. Can I have slides shared, please? All right. Thank you. A very good evening and a warm welcome to everyone. And as I said before I begin, I'm going to take this opportunity to congratulate the organizers, led by Dr. Ghanshyam and Dr. Viraj as well, and also thank them for the opportunity. So like Viraj was talking to you about, I'm going to quickly take you through the role of cabozantinib in advanced neuroendocrine tumors, with the focus of highlight being on these 2 trials, the CABINET study and the cabozantinib trials, which read out at the recent ESMO 23. Next slide, please. So this was the CABINET study, which was a phase 3 double-blind study of cabozantinib versus placebo in patients who had progressed on prior therapy. Next slide, please. So just to set the ball rolling here, I know this is how it all started off as far as angiogenesis inhibitors were concerned. We had pancreatic neuroendocrine tumors and extrapancreatic neuroendocrine tumors. And we all know that it began with sunitinib, and then again to all the other small molecule inhibitors, so TKIs, cabozantinib, lenvatinib, and then the SANET study, which actually led to the approval of surufatinib in China, both for pancreatic and extrapancreatic neuroendocrine tumors as well. So that's how the TKIs have evolved over a period of time. And like we've heard earlier, this is probably one of those first phase 3 trials after a very long time looking at a small molecule inhibitor in neuroendocrine tumors. Next slide, please. So this was the trial study design. We had both pancreatic and extrapancreatic neuroendocrine tumors with 2:1 randomization between cabozantinib versus placebo, and the primary endpoint here being PFS. Next slide, please. And again, as you can rightly see here, most of them had well and moderately differentiated neuroendocrine tumors, and more than 90% had prior treatment with some statin analogs. So you're talking about a heavily pre-treated population here. And again, most of them had received PRRT as well. So you're talking about a median number of lines of at least 2 lines in extrapancreatic neuroendocrine tumors and close to 3 lines in pancreatic neuroendocrine tumors. Next slide, please. So these were the response rates. And as you can see in both the cohorts, the pancreatic neuroendocrine tumor cohort as well as the extrapancreatic neuroendocrine tumor cohort, the response rates were better, probably much higher in the pancreatic neuroendocrine tumor cohort, as you would likely to expect, because that's where we've conventionally seen these TKIs do much better. So you're talking about 18 versus 6% and 4 versus 1%. Next slide, please. So the primary endpoint of this trial was met as far as the improvement in the median PFS was concerned. We're talking about 8 versus 3 months, an absolute improvement of close to 5 months in the extrapancreatic neuroendocrine tumor subset, and in pancreatic neuroendocrine tumors as well. The 11 versus 3 months, absolute improvement of close to 8 months. But what could probably be the reasons for the shorter PFS in the control arm? Again, here you're talking about a heavily pre-treated population, number one, and also the time taken for them to enroll into the study as well. By the time they'd progressed and gone on multiple lines of therapy, it'd been multiple years. So I think those were probably why the control arm didn't do as well. So next slide, please. And these were the overall survival data. As you can clearly see in the extrapancreatic subset, there's absolutely no difference in overall survival. Whereas in the pancreatic subset, well, you could see that there was a semblance towards probably an improvement in overall survival. But remember, this was not the primary endpoint of the trial, and the trial was not powered adequately to answer this question of an improvement in overall survival. This was only a secondary endpoint. Next slide, please. What about adverse events? And again, I think tolerability definitely was a key question here. But most of the commonly occurring grade 3 events were hypertension, fatigue, and diarrhea, and that was common in both the cohorts, extrapancreatic and pancreatic neuroendocrine data. And again, the data on quality of life and patient-related outcomes, reported outcomes are all pending. So next slide, please. So, to put it in a nutshell and look at all the TKI trials with both phase 3 and phase 2. So the first one right on top is a phase 2 trial looking at cabozantinib. And as we all know, phase 2 trials, the results seem to be pretty impressive. And that's why you're getting to see a median PFS of close to 30 months. But nevertheless, even in a phase 3 trial, you're looking at an absolute difference of 8 versus 3 months in the extrapancreatic and pancreatic 11 versus 3 months. So which to me is pretty impressive data. And again, especially in a heavily pre-treated population. And again, the surufatinib data, again, the SANET study, which led to the approval of surufatinib, albeit in China, and again axitinib, pazopanib, and lenvatinib as well. So across the board, you're getting to see pretty good data with these TKIs in neuroendocrine tumors. Next slide, please. What about pancreatic neuroendocrine tumors? I think this is where we've always heard about sunitinib and then everolimus as well. Again, phase 2 data, cabozantinib, followed by phase 3, you're getting to see a huge improvement. And again, sunitinib, surufatinib, and lenvatinib also seem to be pretty good options. But again, you probably talk about phase 3 data, and especially in heavily pre-treated population, like I said, more than 90% had received prior somatostatin analogs and at least a median of 2 to 3 lines of prior therapy. Well, I think that's pretty impressive. Next slide, please. So where would you look at placing it in the current treatment algorithm, be it in a small bowel NET or a lung NET? So at least post 2 lines of therapy, as far as small bowel NET is concerned, you're talking about your first line being somatostatin analogs, followed by PRRT, and then probably you're looking at positioning cabozantinib there. And as well as lung neuroendocrine tumors are concerned, probably in the second line. Next slide, please. What about placing cabozantinib? Where would you like to place it in pancreatic neuroendocrine tumors? I think, we've had excellent data from CAPTEM as far as the ECOG study is concerned. And then we have ongoing trials looking at PRRT versus CAPTEM as well. But again, post either in the second line or post 2 lines in the third line, I think is where we're looking at placing cabozantinib right now based on this data. Next slide, please. So I think definitely the impact on daily practice is that we now have an extra therapeutic option in our armamentarium. And again, in the second or third line of therapy, depending on multiple factors as far as patient preference and volume of disease, burden of disease, and prior treatment strategies are concerned. And again, you're looking at taking it on PRRT as well. And open issues are, the response based on the primary side could definitely be a factor. And if you have patients who have already been on prior sunitinib, well, what would be the efficacy again? And should it be in the second line, third line? What about toxicity and dose reductions? Again, open question. And do we have predictive biomarkers? I think that again will be a debate that will be going on for ages. Next slide, please.
So 4 minutes.
Sure. And yeah, sure. And again, this is the second trial that we're going to discuss today. Again, IO plus TKIs. Atizo plus cabozantinib. This was a basket study, phase 2 trial, the Gabatin study. Next slide, please. So, well, conventionally to put it across, as far as at least neuroendocrine tumors are concerned, we've not had a great deal of success with IO drugs. And we know that there are multiple other pathways involved apart from just the PD-1 and the PD-L1. We talk about the LAG3, the TIM3, TIGIT, and then in IDO pathway, VISTA pathway, and so on and so forth. So we're looking at developing drugs to even target the other pathways as well. And next slide, please. So this, again, this basket trial looked at well-differentiated lung neuroendocrine anaplastic adenocortical carcinomas, pheochromocytomas, and again, well-differentiated and poorly differentiated neuroendocrine neoplasms as well. So as you can see here, role of immune checkpoint inhibitors probably was limited only to anaplastic thyroid carcinomas. And in none of the other subsets really did seem to make an impact apart from grade 3 neuroendocrine tumors, where we know probably MSI high and TMB high tumors would probably benefit. Next slide, please. So this was the eligible criteria. I'm not going to get into the details of that, but I mean, they took in only adult patients more than 18 years, and they must have had at least prior lines of therapy, and only anaplastic thyroid carcinoma they could be included in the first line as well. Next slide, please. So this was how it read out as far as the Sure. So how it read out as far as the response rates were concerned, and you can see here that pretty impressive response rates, close to, even if you talk about disease control rate as well, 75 to 80%. And so this was pretty interesting data because you're talking about an IO plus TKI combination actually making an impact across the board in lung, thyroid, adenocortical carcinomas, pheochromocytomas, and grade 1 to grade 3 neuroendocrine tumors as well. Next slide, please. So again, what about other combinations that have been looked at? Pembro and lenvatinib, atizo-bev, atizo-cabozantinib, nivo-EP, and durvalumab, or your IO plus IO combinations as well. So I think, it's pretty interesting times ahead because now we're looking at this phase as well. We're looking at combinations even in neuroendocrine tumors. Next slide, please. Well, safety concerns again was targeted hypertension. It's pretty consistent with what we've seen across the board with this combination drug. Next slide, please. And again, so treatment discontinuation rates, even in patients who had prior dose reductions. So about 40% did have need for dose reductions. Next slide, please. So, I think, these were the conclusions, and then the limitation of any basket trial is that you're looking at definite heterogeneity across tumor types, and then you're looking at the disease control rates definitely being impressive, and looking at other combinations. Like I said, this is not just limited to only Atizo plus Kepo. You're looking at other IO plus TKI combinations, other IO plus IO combinations as well, and that's where we're headed towards as far as the future is concerned. Next slide, please, and that'll be my last slide.
So yeah.
Yeah, that'll be my last slide. And
Sure.
yeah, thank you. So does the choice of TKI actually matter? Could it be Kepo? Could it be lenvatinib? Could it be any other TKI as well? And what about the dose? And what about prior lines of therapy? They've had prior exposure to TKIs? Is one TKI better than the other, especially at progression? And again, you're looking at combinations, like I said earlier, whereas be it IO plus TKIs, IO plus IO, or IO plus VEGF inhibitors. So with that, I'll conclude and say thank you all for your patient listening.
Thank you. Thank you. Dr. Viraj.
Great presentation, Dr. Krupa. So we will discuss all three abstracts in our panel discussion. Let me call my panelists, Dr. Siddhartha Roy, Dr. Lipsita, Dr. Ganesh Subudhi, and Dr. Amit Verma. Is everybody here?
Yeah.
And just have my organizers open my slides, please. Okay.
Yes, opening.
Request everybody to open their video so that I can see you each. Okay. So since we are short on time, I will straight away go for cases. I have 3 cases, main 2 on colon cancer and then on neuroendocrine. So let's go to case 1, and we want to discuss what Shefali discussed in these cases. So this is a 60-year-old male, no comorbidities, right-sided colon, a pre-op CA of 25, did not have any obstruction or perforation. There were no distant metastases, underwent right-sided hemicolectomy, and this is the stage T3, N0, M0, grade 2, LVI positive, PNI negative, R0 resection, 0 out of 26 lymph nodes, and it was MSS. So let me come to you, Dr. Ganesh. So 2 medical oncologists, Dr. Ganesh and Lipsita. These are the 2 cases. The case is stage 2, potentially high risk. Chemo, no chemo, observation. What are your thoughts?
Hi, I'm Dr. Ganesh. We can observe these patients in this case.
So LVI positive and MSS wouldn't make you feel nervous since it would go quote unquote high risk.
Little high risk there, but we can consider observation / single agent capecitabine.
Chef, what would you do? Fit patient, 60-year-old male.
If the patient, we can follow up this patient, then definitely we can observe. But if we can't follow up, then we can give capecitabine.
No, we can always follow up the patient.
If you can follow up, we can also follow up this patient. Both are, we can go both ways.
Okay. Dr. Lipsita, what would you do?
Sir, good evening. I would be a little, my opinion will be a little different because I would like to go for an adjuvant, probably Capox, fit 60-year male, LVI positive, PT3. I think I'll go for adjuvant Capox. Yes.
What is the benefit? Like in breast cancer, we always say, right, that adjuvant chemotherapy has 4%, 5% adjuvant chemotherapy benefit. What do you think? What you will quote to your patient? What's the benefit in this case?
Since 2 high risk features are present, I would like to go for adjuvant. The advantage of PFS is there, otherwise no other advantage. So maybe capecitabine or Capox, both will do, but adjuvant, yes, for sure.
Dr. Shefali, quickly.
Yes, so I mean, it is T3N0 only single LVI positive. So one risk factor. Again, before
MSS.
yeah, MSS is okay. MSS, MSI, I mean, they are not counted as such in the risk factor categorization. Of course, the treatment decision making would matter. So before the ctDNA era or data, so of course observation would be the choice on my cards.
Okay, next slide, please. So this is the meta-analysis of stage 2 colon cancer. Giving chemotherapy has 2% DFS advantage.
2% DFS, and relapse rate in this setting is 5 to 7%. And to
81%.
treat to save 5 to 7, you would treat 93 otherwise without ctDNA.
So
That
to
would be kept in
save
mind.
2, you need to treat 50. This is stage 2, okay, not stage 3.
Yeah,
Stage
yeah,
2,
absolutely.
to save 2, you need to treat 50, 100. So 50 case treated, 1 you save. So I think we are over treating these patients. Next slide,
Yes.
please. And going on top of that doublet chemotherapy, this is from Mosaic study. I don't see any difference between the blue line and the yellow line. You know, identical, low risk, high risk. In fact, in low risk, the yellow line dips, which is a doublet chemotherapy. And to further complicate things, NCCN further confuses us. It says a survival benefit has not been demonstrated for addition of oxaliplatin to 5-FU-leucovorin in stage 2. However, FOLFOX is a reasonable for stage 2 patients with multiple high-risk factors. So it's contradicting its own stance, NCCN. The truth is, nobody knows what to do, and hence the practice patterns in our country differ so much. Somebody will say observation, somebody will say capecitabine, somebody will say capox. So this is, next slide, please. So this is the scenario we see very often. Next slide, please. Next slide, please. Where these patients were randomized to physician's discretion versus ctDNA based discussions. Okay, you do blood test at 4 weeks and 7 weeks, and if they have MRD positivity, then you give them chemo. If they are negative, you just observe them. And versus vis-a-vis, you compare them to standard physician's choice. Next slide, please. And you can see, I'm sure everyone can see there is no difference between the two lines. In fact, I can see only one line. And what you can see is that standard approach, 28% actually got chemotherapy, while if you did ctDNA based, just selecting those who actually need it, only 15% received adjuvant chemotherapy. So you are halving the number of patients that are required to get this level of survival. So Dr. Amit, let me come to you. How ready are we to use this technology? Because I think this is very good technology where we can reduce the number of patients going on adjuvant chemotherapy in stage 2. Dr. Amit, what are your thoughts?
Yeah, Viraj, thank you very much for the question. I think we're in the interesting times that where we have this very good technology, but we have to understand a very simple concept that this is a liquid biopsy which have lot of variables to take into account, especially the shedding of the DNA, which is quite dynamic and variable. We do not know what we are dealing with. And what we normally say that post-surgery, the macroscopic cells, what are left over, are going to give me the MRD status. So how good are they in terms of really giving me the enough DNA or the ctDNA to have a good yield? So the false negativity is a big question actually. That is one challenge. Second of all, the technology what we are using these days in liquid biopsy is mainly on the genomic alterations. The concept of ctDNA and the concept of genomic alterations are two different things. To add on to this new concept, the epigenetic biomarker are also being added to the liquid biopsy to enhance the sensitivity. So to be very honest, we are right now evolving to really have to pick up the ctDNA that sensitive. We are right now not very sure that we are really picking up all the cases actually.
So Dr. Amit, you are absolutely right. The current 2 tests available in market, Natera and Gardner Trevi, both of them are incorporating the epigenomics as well, apart from genomics in liquid biopsy. And hence they are very close to getting FDA approval in the US market. So I get it, it's a difficult technology to copy, but people are already mastering it. So you think
So
it will
Viraj,
pick up
can
here?
I come in? Can I come in?
Yeah.
So once you see the Pegasus arm, so after K-pop, after
We'll
K-pop,
discuss Pegasus in the next
yeah,
case.
okay, perfect, all right.
Right. So this was the case where I wanted to showcase how we can use liquid biopsy to reduce our urge to give chemotherapy. Now let's go to the next case. Next slide, please. So this is the case, and this is a true case, by the way. 44 male, very close friend of mine, no family history of cancer, again right-sided colon cancer, underwent right hemicolectomy, very bad cancer, T4A, N2, 9 nodes positive, grade 3 LVI positive, PNI positive, MSS. So, he came to me and he asked me on my face, what is the risk of recurrence in me? So, Dr. Ganesh, if this patient comes to you, what do you say, even with your best of chemotherapy? You give your 6 months K-Pox, give your 6 months FOLFOX. What do you think is the risk of recurrence in this patient?
Risk of recurrence actually too high. In this
How much?
one of the cases recently I see from TMS, one patient, young patient, they ability this like burden of disease. They given FOLFIRINOX. After 11 cycle, there is recurrence.
Okay, but yeah, giving triplet chemotherapy. Okay,
Maybe.
Dr. Lipsita, would you agree this patient has a very high risk of recurrence?
Yes, sir. Of course, all multiple high risk features are there. So
Next slide, please. Next slide. So just to put a number on it, this is based on IDEA analysis. The risk of recurrence just at 3 years is 1 in 3. So 1 in 3 patient will recur with your best treatment of 6 months FOLFOX. Okay, and if you wait 5 years, the risk of recurrence is 50%. So, the patient said, doctor, you got to do better. I cannot take a 50% risk of recurrence and accept that this is the best you have. So in this scenario, Dr. Shefali's point would come. Go to the next slide, please. So Shefali, this is the exact patient where escalation of Pegasus comes into picture. And like Dr. Shefali discussed, that the primary endpoint was 2 negative ctDNA should tell us in a stage 3 cancer that you are not going to recur with 90% accuracy. Did they achieve that? Yes, they did achieve that. So in short, this was a positive trial of ctDNA, the first positive trial of ctDNA so far reported. 2 negative ctDNAs, one after surgery and one at 3 months. The risk of recurrence is less than 10%. That was their primary endpoint.
So, but Viraj, there was one point here. So once they tested after 3 months of K-Pox and somebody who turned out to be ctDNA negative and they de-escalated to CAPE, almost 73% relapse. So was that the false positive thing, or was that the short treatment which was not warranted? So that is still a debatable
We'll
thing.
come to that. No, positive becoming negative, that is de-escalation strategy. We are not talking about de-escalation.
Yeah, after de-escalation, again 73 relapse.
Correct.
73%. That was
Right.
the bad part of it.
Correct.
Yeah.
So de-escalation, they failed. They failed de-escalation.
Yeah, they failed de-escalation.
Yes, but I'm talking about 2 negatives. That means after surgery, if you have a negative ctDNA, and then you just do capecitabine and still have negative, the risk of recurrence is less than 10%. And
absolutely. It was 7% only. Yeah.
Next
I
slide,
agree.
please. Next slide. So this is the case what Dr. Ganesh was saying. Next slide, please. That if this patient says, I have 50% and I don't accept it, would you use this trial data that if your patient turns out to be ctDNA positive, you amplify them with irinotecan. And by doing that, you convert them negative from positive ctDNA to negative in about 40% of your attempts. So you think this is a very interesting strategy? Would you use this in your practice?
Really,
okay, please go ahead. Yeah.
Dr. Ganesh?
Actually, I should, as the technology is going to available, I should go by this approach.
Okay. Dr. Lipsita, did you get convinced by such an approach? Of course, small numbers, but very, very tempting.
yes, sir. Of course, ctDNA, if it is available in the center, should be a good approach, sir.
This test is available in India, by the way.
Yes, sir. But few centers do not have, but yes, in our center we have it. So yes, we can use it too, sir.
Dr. Amit, what about your thought on this? I know you have questions about MRD technology, but I think so it is becoming prime time very soon. Would you use that? You're on mute.
I'm very confident and happy if we have the cases where we see a ctDNA positive, escalating the treatment makes sense. But when it is negative, de-escalating does not mean to us anything actually.
Completely agree. So Dr. Shefali and Dr. Amit both said, which is the right part of this slide, that if they become negative, do not de-escalate, because the moment you de-escalate, they start to relapse back. So I agree, de-escalation did not work, but escalation did work in this trial. So let's move on to the next. How much minutes I have? How many more minutes I have? 5?
Anita, how many minutes?
Next slide, please. So just to wrap
You
up,
have 6 more minutes, sir.
great. Just to wrap up, we discussed 2 case scenarios. One where we want to avoid chemotherapy, and one where we want to escalate chemotherapy. I think so in both NCCN and ESMO currently hold the statement that ctDNA is not ready prime time as of today. 3 months back, the NCCN was updated, and the statements were they are not ready prime time. And obviously so, because this is the only randomized study so far reported. But in coming years, this statement is very likely to change. Next slide, please. Now I have a couple of cases on neuroendocrine, and we have a nuclear physician, right?
Yes.
Doctor?
Yeah,
So,
hello, hi.
Hi, Dr. Siddhartha. Now, many questions. I'll come to you. Next slide, please.
Okay.
Next slide, please. Okay, this one. So, again, this is the real patient. I have 54 male, pancreatic neuroendocrine, extensive liver metastasis. Patient was just diagnosed with some little symptoms, grade 2 KI index of 3%. At that time, that patient did not have DOTA scan done. He was treated outside.
Okay.
That's another problem. He was just given Sandostatin LAR empirically, and he did well for 10 months. So I presume that he would have a lot of DOTA uptake or somatostatin uptake. But in 10 months, the patient had poor PS, again became symptomatic, had started weight loss. I repeated the biopsy, and it was more or less same. It was just a lab variation, 3% became 6%, but more or less it was still intermediate grade. How would you proceed in this case?
Hello?
Yes.
Yeah, we don't have the DOTA scan here because G2 is the intermediate grade. So most of the times, sometimes we find that DOTA is negative in those cases, and relying only on the pathological thing sometimes might be tricky. You just have to do both a DOTA PET, and if the DOTA PET is showing negative, then you must go ahead and do the FDG PET. If the FDG PET ability is there, then you are dealing something of a higher grade. So unless you're sure,
What is the cutoff when you order both? Is there a cutoff when you order both, or you just order?
No. If you have a diagnosis of neuroendocrine tumor pathologically, go ahead and do a DOTA PET. If DOTA PET is strongly positive in neuroendocrine grade 1,
what is strong positive? What do you say?
When you have a liver background SU-max, the DOTA, the lesion, target lesion should be at least 3 times higher than the liver SU-max.
3 times, okay.
2 to 3 times, yeah. That is a significant focal uptake is there. We consider this is positive. But what we get is an intermediate grade. There is a intermixing. There will be few lesions which are DOTA negative, few lesions which show DOTA positive, and the uptake is on the lower side. And we go to grade 3, there's hardly any uptake.
I agree. So this patient
3 minutes, sir.
Yeah, this patient had DOTA uptake. Would you go for PRRT?
Oh, yes, definitely. Because extensive liver mets.
So far, PRRT, all the studies have been in extra pancreatic neuroendocrine GI.
GPs mostly, GPs, gastroenteropancreatic. Includes both.
So randomized phase 3 study nahi hai, and hence even what Dr. Kripa Shankar showed, the ESMO algorithm, PRRT comes later for pancreas. while it comes right in front for small bowel or
Yes.
other GI NETs. So do you practice that ways, or just blanket PRRT goes second line? What do you think?
Ideally, if it's a GEP, obviously the PRRT is way front. But in case when a patient has a progressive disease on DOTA PET and DOTA avidity is there, we go ahead and do a PRRT. Because
Dr. Yuktida, PRRT or CAPTEM? Pancreatic neuroendocrine, we have excellent data on CAPTEM. What do you think?
CAPTEM, sir.
Even DOTA uptake is there. And Dr. Sadatta is working in your hospital. Still? Because this is a true MDT discussion, right? The nuclear guys wants to do PRRT, which is not wrong. Of course, there is no strong data, but we all have seen the results. It's amazing responses. At the same time, we have data on CAPTEM.
Right, sir.
So what would you do?
CAPTEM, sir, still.
CAPTEM, still CAPTEM. Okay.
Well, we can have CAPTEM and then keep DOTA for the later. If the patient progresses, then we can give DOTA later.
Correct.
So we are left with a minute.
Yes. Next. Go next. Okay. So this is the last slide. Recently me and Dr. Bhavna Siroi wrote a review article on pancreatic neuroendocrines, and it's under review. It's for a journal. And this is the algorithm we came up for our Indian patients. And why I say Indian patients is because we've included lenvatinib and cabozantinib also in this algorithm, because we have them freely available in generic form. So, Dr. Ganesh, where would you place CAPTEM in your practice? And where would you place the TKIs? Like Dr. Krupa Shankar mentioned about TKIs, sunitinib, lenvatinib, cabozantinib. How would you place them in your practice?
Actually, if you patient is very much symptomatic and Ki-67 a little high, then we can obviously use capecitabine and temozolomide. But if the Ki-67 is very low and grade 1 or 2, these all we can always use TKIs.
Okay.
Time is up, actually.
Yeah, so I think so. I wanted to end with this algorithm, and we can further discuss later on. Thank you so much. And thank you for wonderful panel discussion.
Thank you.
Thank you, sir.
Thank you. It was wonderfully done, sir. Thank you so much. We quickly proceed to session 3. Moderator will be Dr. Ghanshyam Biswas, sir. Sir, over to you. This session is sponsored by ISI.
Please allow me to share my slides. Somebody please allow me.
Sir, doing it, sir. Just a second.
Take time now. It's wasting time.
Are we done, Anita?
Oh, yes, sir. You can share the screen, sir.
It's not available. Who's
So
this?
can you share the screens from my end?
Please.
Yeah.
It does take time. No? That's the reason. No? So Dr. Sachin, Dr. Sushant, Dr. Suresh, Dr. Shruti, all are there?
Yes, sir.
So thank you for joining. So thanks Isai for this opportunity. So in next 25 minutes, let's unleash some certain factors in an undetectable hepatocellular cancer. So we'll discuss out first line in regards to etiology and the treatment per se. So will this affect your systemic treatment selection? Next. So that's the problem. Yeah. So what do you see common in these four, being besides a medical oncologist? Sachin.
All are starting
S to
from
the power 4.
So next. So all medical oncology is starting with S.
Yes, sir.
Go ahead. It's fixed. Yeah.
Next slide, Anita.
All S, right. So now coming to etiology and SCC. So Sachin, just brief etiology 1, 2, 3, 4.
Sir, most common any reason for cirrhosis is a reason for SCC. Most common is post-viral hepatitis B and C. Apart from it, alcoholic cirrhosis and non-alcoholic fatty liver disease, primary biliary cirrhosis, or other diseases causing cirrhosis.
Right. So Dr. Sushant, so have you seen any changes in the etiology in last 1 decade?
Yeah, the viral induced hepatocellular carcinoma now decreased, and other non-viral causes of hepatocellular carcinoma was increased.
So you go to Dr. Suresh Babu, so all from Bengaluru. So Dr. Suresh Babu and we had a good time in ESMO. So Dr. Suresh Babu, so how common is SCC in your part?
We are seeing a quite good number of it. I think I agree with the speaker previously before that NASH is being a leading cancer in HCC now. I mean, it is increasing nowadays, though viral hepatitis remains the main cause in our center as of today. One of the things is that probably for viral hepatitis, we have many drugs like from gastroenterology coming in. So that may be the reason why viral hepatitis is taking a backseat, and and the other problem, maybe we are not aware of NASH before, we were not looking into it particularly. So now we have started looking into NASH because of all these clinical developments recently. Maybe we are identifying NASH much better than what we used to do before. So before for us, all HCC were same. Now we are trying to looking into the etiological factors. So the trend is changing. The NASH is definitely increasing, catching up compared to the other etiology.
So next slide, please. So everybody have alluded to the complexity of etiology. So definitely viral related disease is coming down. So even the alcohol part, so lots of metabolic factor. If Shruti is there, she was in the OPD. So have you started differentiating between viral versus non-viral? And how do you tackle your patients in OPD who comes with a moderate fatty liver or a grade 1 fatty liver? So do you send them to a gastro? And so what sort of suggestions you give? Shruti?
Yes, sir. So I agree that there has been a shift in the etiology of HCC, and more commonly we see non-viral related, non-alcohol related HCC. But I agree we do take the reference of the gastroenterologist, but most of the times it is not. I mean, there's no specific therapy for these patients, so the patients also are very reluctant for getting another reference, because most of the times it's an advanced disease and they're already have been juggling from one doctor to another during the diagnosis part. So I mean, uh, for viral related HCC, of course we start the antiviral at the same time, so the reference is almost always done. But for non-viral, I mean, we do ask the patient, but unless it's an end stage CLD or something, they are very reluctant.
So absolutely. So next slide. So like the gynec doctor, when he sees a patient who is pregnant, so he sees two patients, the mother and the child. So somebody who treats SCC, so he or she is dealing with a cirrhosis and a malignancy. And above all, if it is a viral, then definitely so there is a viral factor. So in your opinion, does the liver disease etiology have an impact on the natural history of patients with unresectable SCC? So going back to Sachin, yes, somewhat no, just.
Yes, sir. Yes, sir. Definitely. The etiology of
Shant, unmute.
Yeah. Sir, definitely it is a challenge to deal with.
Yes, somewhat no. So the answers.
Yes, definitely, yes.
Not a Suresh Babu.
Definitely it is.
Shruti. Next slide.
I agree, sir. I agree.
So now coming back to, does the liver disease etiology influence your choice of first-line systemic therapy for unresectable SCC? So ladies first, Shruti. Shruti, unmute.
So somewhat it does impact.
Dr. Suresh Babu?
Yes.
Yes. Okay. Sushant?
That I consider medical oncology point of view, that the treatment pattern, the oncology treatment definitely not much affected, but I agree with the answer is somewhat, not definitely yes.
Sachin?
No, sir.
No. Chalo. Next. So now, so just a brief. So your take. So let's see some evidence. So I am brave 150. We know it was sorafenib versus combination of immunotherapy plus bevacizumab. Cosmic was cabozantinib and meta-analysis. Any idea about this? So next slide, Sachin.
Sir, I am brave is about atezolizumab and bevacizumab in first line in fitter patients.
Next. So definitely fitter patients, since we are adding VEGF, so definitely we will look at the varices. So if varices, then probably you won't take it. So this was atezolizumab versus sorafenib in unresectable. So phase 3 trial to 2:1 randomization, and so OS was the primary co-endpoint along with the PFS. Next. So how do you interpret Dr. Suresh Babu on this slide? So though this is a subgroup analysis, suggests that Atijo plus Bev has a limited benefit to the patients with the NASH etiology. I've just made it a green circle. So how do you take this?
The various mechanisms have been explained why immunotherapy is a not good drug to be given in NASH. I think one of the explanation given is that the patients with NASH do have expression of CD8 and T cells compared to they lost the CD4 expression. So thereby that immune mechanism may not work. The other explanation given is that when you have a NASH associated HCC, the gut microflora is affected. So thereby the peripheral immunity can be affected. These are some of the explanations given. Immunotherapy does work in NASH also, but not to the extent where the viral etiology is there. So we do have other drugs to work in that. So in that way, so immunotherapy may not be a suitable drug for a first starting of NASH-related HCC. That's what my opinion is.
Absolutely. Absolutely. So great explanation. Next slide. So this was a Cosmic 312. So this was Cabo with Atijo. So here Bevacizumab was not there, with sorafenib as a first line treatment. So there were 3 arms, 2:1:1. Again, so we are looking at, so next slide. So here you can see on the left hand side, so Cabo Atijo versus sorafenib. So HBV versus SCB versus non-viral. So you can see, so lots of events in the Cabo Atijo. So this was on the PFS. If you go to the right hand side, OS again. So in the non-viral, in the OS you can see. So this probably shows some. So in the non-viral, the IO combinations where the hazard ratio is more than 1. Next. So this was the Cosmic 312. So the upper part of the slide is for a median PFS and the lower part is OS. So starting from left to right, so hepatitis B versus hepatitis C versus non-viral. If you see the brown one, which suggests with combination of IO, and the yellow one is the TKI, this is sorafenib. You can see PFS. So PFS, which was 6.7 versus 2.7, more in the viral, whereas you can see that separation is not much there when there is a non-viral etiology. And if you look at the OS, again you can see the non-viral, the sorafenib are not reached. So does it make significance? So Sachin. So now Cosmic 312 and the I am brave 150.
Sir, I think it is significant, sir.
Or at least a trend towards like differentiating?
Yes, sir.
Shruti, your take? Next slide. So the NFLD associated SCC and response to immunotherapy, I think Dr. Suresh Babu has already alluded. So NASH limits anti-tumor surveillance in immunotherapy treated SCC. Next. So this is a meta-analysis. So you can see the upper part was a non-viral with, so all the 3 immunos like the Nivo, the Keytruda, and even the Atijo versus in the viral etiology. So you can see all the diamonds are not favoring the IO in the non-viral etiology. So meta-analysis of the 3 large phase 3 trials shows that IO improved OS in the overall population in viral, but not necessarily in the non-viral. On the right-hand side, you can see a cohort of 130 patients with NFLD was associated with shortened median overall survival after IO. So if other etiology where the median survival was around a year, 11 months, but in the NFLD, it was less than 6 months. So it was non-viral versus the other etiologies. Next. So what could be the probable reason that non-viral SCC patients do not respond well to IO therapy? I think so. Dr. Suresh Babu has already alluded to. Next. So these were some of the reasons. So one of the reasons being after anti-PD-1 antibody acquisition, so extended the liver fibrosis, and in the NASH, SCC T cells are metabolically activated and consequently expresses high levels of PD-1, but at the same time they are auto-aggressive. So immunotherapy with PD-1 or a PDL-1 leads to survival of the T cells, which are unexpectedly becomes a pro-inflammatory, and that gives rise to more of fibrosis. Next. So that's why, so this was step 1, step 2, and step 3. Next. So NATS limits anti-tumor surveillance in an IO-treated SCC. So additionally, it was observed, as again rightly said by Dr. Suresh Babu, the CD8 positive PD1 T cells were also dysfunctional for effective anti-tumor surveillance. So leading to worse outcome in the NFLD SCC patients receiving anti-PD1 immunotherapy. Next. So now coming to Dr. Suresh Babu. So what is real-world evidence or real-world studies? So and what has been your observation in a real practice?
So to be very frank, I have not looked into that real-world practice because this data is coming down very recently. And another one factor what I have seen is that most of our HCC patients, when they come, they are not even fit for any treatment. So I have treated them. Some of the patients before this data come, I have tried with immunotherapy in some of the patients. Even with hepatitis, we didn't have NASH, we didn't have a good experience at all. But somehow lenvatinib seems to be a better drug in NASH patients. The quality of life is good. They seems to be doing well. So even with those compromises, I think that the lenvatinib is the good drug in NASH. In hepatitis, one of the issue is that if a patient is having active hepatitis, then the immunotherapy part will take back. But otherwise, in NASH, lenvatinib is doing well. So in hepatitis patient who are viral loads are little low, immunotherapy is the way forward. That's what I think.
So Dr. Suresh Babu, would you like to give one of the thesis to your next coming DM students?
Already, but the problem is the number of patients in immunotherapy is quite less. So to match the arm, so for the NASH with the lenvatinib, we have a data. We are planning to go for publication in few months.
So you have a nearby colleague, Dr. Amit Rautam, so who gives lots of immunotherapy. So that can be a control arm. So next slide, please. So Sushant, so how has been your experience with using lenvatinib? So at 8 milligram or 8 to 12 milligram, so how often have you reduced the dose, and what has been the toxicities and the responses?
Lenvatinib more than 15 kg, we are giving 12 mg. Less than 50 kg, we are giving 8 mg. Then about the tolerance is good. That if patient has childhood A and B, they can well tolerated the lenvatinib, the prescribing dose. Currently, I have only one patient on lenvatinib last 1.5 years, and he is doing well.
But I remember one patient, Sushant. So you had a patient who was non-viral who survived for 3 years on Keytruda. You remember?
Yeah, that lady. He consulted you also. Right. That lady finally died with, I think somehow the PET CT scan was suggestive of necrosis. We did biopsy also. That came again necrosis, no active disease, and died with liver failure.
So that is going to happen. So because the functional liver component is not there. So Dr. Shruti, so how has been your experience with using lenvatinib? Yes, Shruti. Sachin?
Sir, in my experience, lenvatinib is a very well tolerated drug in HCC population, and patients are doing quite well on lenvatinib because most of the patients are not able to afford the IO therapy even if we plan.
So Shruti, so switching over from sorafenib to lenvatinib, so which has been an easy drug for you? Next slide. So Sachin?
Yes, sir. Sir, lenvatinib I think is a better tolerated drug than sorafenib. About the PFS part and I'm not sure, sir.
So we'll come to that reflect study because so after a long, almost a 1 decade of hiatus, so that a new drug came. So 2008, then 2018, sorafenib, then lenvatinib. So reflect study next. So lenvatinib showed improved responses, so improved PFS, but again, it was as compared to sorafenib, lenvatinib has a non-inferior OS. So you can see, so median OS was almost the same, but they had improved responses, which was almost 2.5, 3 times, and a PFS almost double. Next. So that was OS, and you can see a PFS and time to tumor progression, which was almost double. Median time to tumor progression and median progression-free survival. Next. So what is your in clinical experience of IO based? So Sachin, any experience of using IO or combinations either alone or in combination with bevacizumab in HCC?
Sir, I had treated one patient only who received Atizo plus Bev. The patient was lost to follow-up. As far as IO is concerned, we have treated patients with nivolumab, and the tolerance is good. And as far as tolerance is
comes when you're using both the drugs. So with immunotherapy alone, probably things are easy. Dr. Suresh Babu, in your private practice at 40s, so you have good number of patients on IO. You may not have in Kidwai, but in your private practice. So any experience you can share, any good experience, patients surviving for a year or two?
5 patients Atezo plus Bev. One of the patient has been doing very well now a year or so. In couple of patients, initially they responded very well for 4 cycles. Then after the 8 cycles or so, the AFP started increasing. But in some patients, I have seen very good response. Atezo with Bev, I thought it's very well tolerated. I had not come across any issues. But one patient's, I am still waiting that patient's viral markers are quite high. So I'm just waiting for that to settle down. Patient is an antiviral therapy, but some of them really did well. Some of them progressed immediately after showing initial response. This is my experience in with VEGF.
Sushant, any experience of using the combination? So we discussed about your case, so which was a single agent Keytruda. So any experience of using both combination of IO and Bev?
No, I am not able to use that. Most of patients come with, and they are not. The PS is also not good, and the child book score always B or C. So very difficult to use this costly medicine in this type of patient.
I think in the Roche now they have come up with a good support. So in a way, so if the patient can purchase 3, so 14 doses will be free. Shruti, are you there still hanging on?
No, sir. She has somehow left the meeting, and we are left with 5 minutes 30 seconds.
Okay, next slide. So now coming to all real world, so there are a good number of patients from good number of countries like South Korea. Next. So median OS and median PFS were not significantly different between the lenvatinib and Atizo Bev group. So next. So now Dr. Suresh Babu, so now you see, we have seen in all those CDK4/6. So we tried to have a real world data, like we had a palbociclib. Now we have from the ribociclib also, and now so these people also have started collecting the real world data, real world studies, real world evidences. So we do understand that in a clinical trial and the real world are totally different. So because there are many caveats. So in a clinical practice, probably even in child be somebody who is affording, you may give it. So in clinical studies, you may not involve. So what has been your experience?
The real world data is complete. The other thing about the the real world data, looking at the lenvatinib and other thing issue is that we have not particularly looked into NAFL related HCC. Non-viral means the alcohol also will come into picture.
Right.
So that you have to keep in mind. So when you differentiate between NAFL associated and alcohol, maybe the lenvatinib could work much better in the NAFL compared to alcohol. So real world data, this has been some issues when you go into the retrospective and other things. You may be able to differentiate between hepatitis related HCC to that are the non-hepatitis, but the alcohol and non-alcohol related really confusing, because there could be some patient who is having underlying fatty liver disease, addition of alcohol may exaggerate. So that could be one of the confounding factor looking into the real world data. But end of the day, if you have viral related HCC, we have very clarity that immunotherapy with VEGF could be a way forward. So in other diseases, you can try the lenvatinib and see alcohol factor may be one of the confounding factor when we look into it.
Absolutely. So like we are trying to separate viral versus non-viral. Sachin, so do you think, so viral is one, alcohol is one, and then the third group is non-alcoholic, non-viral. So would it make more prudent?
Yes, sir.
So next slide, please. So in your opinion, is there any difference in the outcome in viral and non-viral HCC's treatment with the lenvatinib? Sushant, have you seen any idea?
I think if you treat the viral etiology properly and here give lenvatinib, I think it may be the good. But in non-viral cases, lenvatinib will work better.
Next slide, please. So would non-viral HCC patients...
So 1 minute.
So would non-viral HCC patients benefit from treatment with a TKI rather than an IO-based regimen? Next slide. So here so we have already discussed this part. Next. So this shows that in NASH and the NFLD, lenvatinib reduces the risk of death by more than 50% and the risk of progression by around 50% as compared to atezolizumab. Next. So again, multivariate analysis has showed them there is an edge for lenvatinib in the NASH and NFLD related HCC. Next. So next. So now the last question. So start from Sachin. So could etiology be included in the guidelines as a factor for the selection of first line therapy, or should etiology be considered as a routine part of clinical decision making? Yes, no.
Yes, sir.
Sushant?
Sir, who should include?
I think both are, either you make as a clinical decision or the recommendation, you will look into etiology where with the coming out. If you make it as a guidelines, fair enough, but there could be some other data coming in trying to change that. The other issue of doing guidelines for the selection of in first line, that lenvatinib does also work in the viral hepatitis this thing, but immunotherapy could be a better drug, but lenvatinib also works. So making guidelines should not make us more for the medical legal things, and let us keep it open and be happy.
Till that time, we will have more data to collect. Next slide. So in your clinical practice, will you consider the liver disease etiology in your choice of systemic therapy for patients with unresectable HCC? So tomorrow, Saturday, half day, so you go to OPD Sachin, so you see a patient. So now what do you do? So yes, somewhat no.
Yes, sir.
So next slide. So next slide. So to conclude, so before I conclude, I give really a thanks to SI for the sponsorship and a big thank to my good friend Amish Bora, who is next in the line as a debater. So I have borrowed his slides. So his mehnat has been there. So results from randomized clinical trials suggest that it may be important to consider the etiology of HCC when choosing a treatment options for patients with unresectable HCC. So real-world evidence supports the efficacy of lenvatinib in NAFLD and NASH-related HCC, with NASH found to be positive predictive factor in the treatment response. So clinical trial meta-analysis suggests that IOs may be less effective in the treatment of patients with this non-viral etiology associated SCC. So existing evidence suggests that first-line lenvatinib is an effective treatment in patients with advanced SCC of either non-viral or viral etiology. And in real-world studies, the well-balanced patient characteristic. So after matched analysis, so lenvatinib showed a higher treatment efficacy in case of non-viral. The etiology of SCC could help better tailor treatment till the time most of the other results pours in or most of the real-world data gets collected. So thank you. Next slide. So thank you, friends. So especially Sachin, Sushant, Suresh, Babu, and Shruti, all S for a
S to the power 4. Thank you, sir. Thank you so much. It was a wonderful session. We quickly shift towards our next discussion, the next session, management of rectal cancer. And we started in the most interesting way as a debate on the topic radiotherapy-free management of rectal cancer. Are we there yet? So it will a little bit fire the radiation oncologists, but we have to speak in favor of it. We have Dr. Amish Vora, sir, from Bangalore. Hello, sir. Seeing you after a long time. And we have against it Dr. Trinanjan Basu, radiation oncologist from Mumbai. And finally, it would be the expert opinion would come from Dr. Sanjeev Kumar Mishra, radiation oncologist, Bhubaneswar. So we have a radiation oncologist as an expert opinion. All the best to both of the debaters. Over to you, Dr. Vora, sir, please. We have Dr. Vora, right? I saw him. Anita, any problems?
Sir is there, ma'am. Just a second.
Yeah, sure. So I'm thankful to all the speakers who are complying to the time limits, and we are going good. We have had really, really good and a lot of enriching, knowledgeable sessions that would, like rightly said Dr. Ghanshyam Biswas, sir, tomorrow morning when we go back to our OPDs, we would have something at the backdrop of it. Hello, sir. Good evening.
Hi, Promila.
Hello,
Hi,
sir.
Romila.
Hello, sir.
Sorry, I am fixing my laptop has just conked. Can we start with the no first and then I can be yes first, if that is okay. Otherwise, in 30 seconds, I'll be ready.
Yeah,
So
I'm fine also. Can you? And this is
do
Dr.
we
Basu
give it
this
to
side.
Dr. Trinanjan? Yeah, Dr. Basu?
Yeah, because we also have our hospital annual day program. Sorry, so I'm logging in from phone. I've shared my PPT, so can you please share?
Yes, sir. I'm sharing your PPT.
Yeah.
So we start with the against the no, Dr. Basu. All over to you. All the best.
Thank you. So as the PPT gets loaded, thank you, Dr. Ghanshyam and Viraj, for the kind invitation. I was waiting that I will speak second, but since, sorry, we somehow have our hospital annual day program, so I'm also totally stuck. So I logged in from phone with very limited signal here. So anyhow, so I have to speak for favor of not still omitting radiotherapy for management of locally advanced rectal cancer. Next.
Next, Anita.
Just
Can you make it full screen, please?
Yeah, I'm doing
please?
it.
Yeah.
Is the slides are visible?
Yeah. Fine. Yeah. So, generally, from any technology, be it technological advancement in surgery, medical oncology, or radiation, we expect certain things as we apply them. We expect the most that there should be a change in survival, be it terms of local control, a progression-free benefit, or the most and the best if we get an overall survival benefit. If not, then we look for a better toxicity profile, a better tolerability and compliance. And especially in rectal cancer, we also have endpoints like quality of life, both patient and physician reported. Next slide. So we have these two established treatment regimes for rectal cancer, locally advanced. If on a very high T and N, we have the short course followed by systemic chemo combination as in Rapido protocol, or we have Prodige, which is chemo followed by chemo radiation, a long course, and then surgery. And these are two very well-established protocols with its own merits and demerits. and the debate will continue. Next slide. And in between, we have this punch of prospect. The prospect has given a lot of prospect to non-radiation oncologists in rectal cancer. So I've borrowed this diagram. You all know Dr. Kanucharan Patro. He shares a lot of anecdotes and slides and cartoons on daily basis in different platforms. So this particular slide is from him. So we know the prospect trial recently published in NEJM from the Deborah Schrag group in MSKCC. It was a long and well-conducted trial over around close to 1,200 patients between June 12 to December 2018. And it has a cohort of doing only FOLFOX chemo before the surgery, which the patient is getting a good response, not doing radiation, rather omitting radiation and undergoing surgery with an optional of adjuvant chemo, and all the parameters, the overall survival, the local recurrence remain similar. It was a non-inferiority design, means to prove that omitting radiation has been safe. Next slide. So the few points I thought to highlight is that there are only 15% of low rectal disease in each group. There were T3N plus in about 50% in each group, and 15% of the patients in a trial conducted across US and Canada still had no MRI staging. So are we really certain about this T staging in today's time? Next slide. So these are the curves to see for the overall survival benefit, progression-free survival benefit, and everything leaks freedom from local recurrence. Everything the curves are hugging. Next slide. And then few other more important points to highlight. If you see the completeness of the resection, the R0, similar in either of the arm, the pathological complete response, similar in both the arms, so as the YPT0, YPN0 status, and we want a pathological complete response grade 0 or 1, which is also quite high in either of the treatment modality. Next slide. So this led to an array of publications in news media, social media, even a lot of scientific materials. So people can be spared of rectal cancer, of the horrendous side effect of radiation. They can skip that. This is practice changing. This is from the PI herself. The patient with specific clinical stage of rectal cancer now can skip radiation. They can preserve fertility. In a younger cohort, they have an option of not undergoing radiation, and then spare them from the deleterious and disastrous side effect of radiation. The co-PI, Dr. Allegra, who conducted the physician and patient-reported outcome data, also quoted that, yes, this is very important in terms of long-term toxicity, and everything seems that only radiation is causing all these long-term toxicities. Next slide. So as this was going on, we have another new kid of dostarlimab. It is a PD-1 blocker. So for the mismatch repair deficient rectal cancer in a metastatic setting has definitely a role of PD-1 blockade. The same concept being translated into locally advanced rectal cancer on a small phase 2 study given dostarlimab every 3 weeks into 6 months for stage 2, stage 3. 12 patients had at least 6 months of follow-up till this was reported in NEJM, and they were showing clinical complete response. So of course, they did not undergo any surgery or neoadjuvant chemoradiation, which was an option if they are not responding to dostarlimab alone. There are, however, no reported grade 3 events till it went for publication, and they kept as primary endpoint to be durability of the response, means sustained clinical complete response at 12 months. Next slide. And parallelly, the prospect also reported the patient-reported outcomes. And if you see the patient-reported outcomes, be it acute, next slide, be it late, next slide, and the quality of life curves reported, they all are more or less similar at one point. The chemotherapy arm, initially the FOLFOX arm, had more acute toxicities, but as they reported, at 1 year, the curves seem to be similar, and rather the radiation, the NSETRT, the standard treatment arm, had more of these toxicities. However, the overall health-related quality of life, you can see that again, these are not really separating well. Next slide. So what are the points of concern? Are we really happy as a scientific committee to omit a modality which was there for over decades and undergone has a lot of improvisation? They have clubbed T2, T3, N plus together. Is it really nice to club all of them together and omit and modality and then say, yeah, we are right? There is no scope of wet and urge approach in this in T2, T3 low rectum. However, their whole low rectal cohort was low. And the world is slowly moving into an TNT approach, which is then why if an early stage has to undergo after chemosurgery in today's time. And I felt from an analysis, this was over treatment for T2 disease. And the long-term data of the FOLFOX adverse events is yet to be reported. And parallelly, the radiation volumes has changed for other colleagues to know.
We have 1 minute left for you, Dr. Basu. Sorry.
Yeah. With doing IMRT and image guidance, it has changed. So are we ready to adopt a single trial-based practice change and small number of patients trial reporting as a practice change? Next slide. So there are a lot of changes. Even a CT2N0 after NSCTRT can undergo a local excision alone, not those long surgeries. There are limitations in radiation volume for early stage T2, the Star Trek trial going on for mesorectal RT alone. There are proton options, and there is definitely a role of organ preservation. Next slide.
30 seconds.
And we know the proton data. The next slide. And the controversies will remain. And this is not the only option one has to keep in mind. The world is evolving. There is a lot of changes in management. So all these approaches may be true, but one has to know from a patient-centric point. Next slide. So next slide. So we have to answer all of these points for stage 2 and stage 3 before jumping into omitting any treatment. Next slide. So I'll keep this for rebuttal. I'll keep it for rebuttal. Yeah. Thank you.
Can we have now Dr. Foda, sir, please?
Yes, I'll share my screen.
Yes, sir, please.
No, host has disabled participant screenings sharing. Can somebody give me sharing rights?
Anita, can you please work on it?
Yeah, doing it.
रोमिला आप एकदम कड़क ही सबको 1 मिनट बचा है 30 सेकेंड्स बचा है अब 10 सेकेंड्स बचा हुआ है
वो टाइम to neck टाइमिंग है सॉरी
I know whenever you have given me the rights let me know please
Sir, can you please try sharing now, sir?
Okay, I will start sharing. Yes, I can.
Okay, perfect.
And am I audible?
Yes, sir, absolutely.
And audible my time 8 minutes, na Romila?
Yes, sir, 8 minutes.
So my time starts now. Okay.
Yeah.
My apologies. I was supposed to speak first, but because of technological issues. So I would again revise that the treatment of locally advanced rectal cancer without radiation, are we there yet? That is the topic. And it's a debate. And I'm supposed to say yes, yes, and yes. So whenever I say yes, doesn't mean that I have to just say yes. That's why I'm saying only if I believe, then only I will say yes. So let's see. Whenever in India, Dr. Shyam Agarwal and many other seniors have told me, Amish, NCCN guidelines kahan pe hai? So I said, let me start with NCCN guidelines. And before we start, in operable colorectal cancer, we always used to argue. I would argue with Viraj Lavingya. सब पेशेंट में MSI क्यों करना है? एडजुवेंट सेटिंग में तो कोई रोल है नहीं. But now, as we see in the adjuvant setting also, we have got the role of MMR. And why I'm saying this, we will quickly go through it. So any patient of T3, NEN, T1, T2, N1, N2, if they come to us, normally we will do MSI, of course, apart from other biopsy and markers. If they turn out to be DMMR, checkpoint inhibitor or immunotherapy, we give as a single agent. Okay, we give for 6 months and we find complete clinical response. And what do I see here? Just surveillance, nothing else, no role of RT here. And there's a locally advanced rectal cancer. Okay, we say DMMR only in 15% of patients, remaining 85% patient ka kya? So let's look at PMMR. In PMMR also, if we give only chemotherapy, and this is NCCN 6th version 2023 downloaded yesterday night. Chemotherapy alone, after chemotherapy 12 to 16 weeks, you restage with either MRI and sigmoidoscopy. And if you find that there is more than 20% regression in the tumor, you do surgery. After surgery, what do I see here? Surveillance. Oh shit, again no role of radiation. What is happening? In 2003, when I gave my DM exam, trust me, I would have failed if I would have told that rectal cancer can be cured without radiation or surgery. But today, in 2023, it is true because we have to change with times, otherwise times would change us. So there are three major practice-changing advances in rectal cancer in last decade has happened, which are establishing the fact what we are talking today. One is total neoadjuvant therapy. Surgery may be optional. One. Immunotherapy alone, surgery and radiotherapy is optional. And prospect trial, GI ASCO 2023, chemo followed by surgery, no radiation, RT optional. Now, these are the three major changes which have happened. Very quickly, I'll go through the three in next 4.5 minutes. This is an immunotherapy trial and my opponent has nicely spoken. One of the most important thing we need to remember that still we have yet to see the failure. Not a single patient as per report had failed. And in GI ASCO 2023 January, 14 out of 18 patients are followed up beyond 18 months and they are still showing sustained response. TNT, I completely agree, can't be ignored. In fact, this was one of the main points, and that's why it is said that in the era of TNT, does the prospect trial really hold true or is it the thing of past? 6 trials have reported TNT. We can't ignore that. And organ preservation is preferred by 80% of patients in the survey. And this is the OPRA trial, 3-year follow-up, where chemoradiotherapy followed by chemotherapy followed by surgery, 50% patient organ preservation. But the question still remains that are we over-treating some of these patients? We don't have a comparable of chemo alone with surgery or surgery alone. In Europe and in ESMO guidelines, still surgery alone is one of the options. So to answer that question, these academic groups in USA came together to do this trial, which was reported in New England Journal of Medicine in July 2023. Before we go on to the details of the trial, I want you to look at the results. Disease-free survival, the curves are matching. Overall survival, the curves are matching. And the freedom from local recurrence, you see, is almost close to 100%. Doesn't look like anybody is relapsing. And why was the prospect study done? Because first we started with post-op chemoradiotherapy, then we went up to CTRT followed by surgery. But the advent of total mesorectal excision started raising the question whether RT is required or not. We were using RT because pelvic recurrence were very, very suffering.
Sir, 2 minutes, sir.
At the same time, the downside of this thing is up to 20 years, you keep suffering from side effects of radiation. And that's why this study was done, where the comparator arm was pelvic chemoradiotherapy followed by surgery versus chemo alone. Post-chemo, if more than 20% response, you give surgery and adjuvant chemo, no radiation. Primary endpoint of disease-free survival at 5 years, same non-inferiority trial. Most important thing is you are worried about the local recurrence. Chemo alone, 98.2% at 5 years did not recur. What more do we want? Again, as I said, these are the trials. So what do we conclude here? Again, as I said, there is no right answer in 2023. Individualized treatment decisions are going to be the future. TNT followed by surgery, TNT without surgery, only immunotherapy, or chemotherapy followed by surgery without radiation. All options are going to be correct. You have to select the right patient. That is most important. But 2 things are sure. Rectal cancer can be cured without compulsory surgery or RT. And treatment of rectal cancer without RT, are we there? Yes, today's topic. Yes, yes, and yes, in select group of patients. And I'm done. Thank you so much.
Oh, wow. You saved us a minute and a half. Thank you so much. Dr. Basu, can we have you for the debater?
Yeah, sure. Can you share the slide?
Anita, do we have the slides ready?
Dr. Basu already knew what I'm going to say and he had the rebuttal slides ready.
Rebuttal is ready, yeah.
I'm sharing the slides.
Yeah, do it fast, Anita. Dr.
Sorry,
Vora saved us such precious time.
I have to stop. I have stopped.
Is this slides are visible?
Last slide.
He
Towards
had
the
one
end,
rebuttal
like
slide at the end.
rebuttal
Yeah.
slide, yeah.
Yeah, there's a rebuttal slide name.
और नीचे आ जाओ.
Yes.
Yeah. The previous one, this one. So we
Yeah,
start
next,
now,
next.
all right?
Yeah, next. Yeah. So I purposefully kept a previous.
The previous one, Baba. Anita, huh?
Yeah, stop here.
Yeah. I purposefully kept a rebuttal slide from the two seminal bodies because this created a lot of havoc in social media. So I kept what Istro and Astro has commented. This is not my personal comment. That's why I kept a slide for rebuttal from what the two seminal bodies of radiation oncology across globe are saying. Yes, this was a non-inferiority trial. So remember, it was not to prove that one modality can be omitted. It is to prove that one more option can be given to patient, as Dr. Vora rightly said. We are yet to see the toxicity of FOLFOX in long term. The initial acute toxicity is almost double compared to NSCT-RT. So that is something to ponder upon, especially in our cohort of patients. The oncological outcomes are similar. In a trial done in US, Canada, 15% of them lack baseline MRI. I don't think rectal staging is complete without that in today's time. The wait and watch and TNT not considered. And even if we have to
Time
treat
is
this
up.
T2, T3, say we lot of data of doing contact X-ray and brachy. We recently have the OPERA trial result also published. So these are important point to see. Eventually, yes, finally, maybe patient is supposed to decide. This will be the future one. Thank you.
So, Dr. Vora, can we have your rebuttal?
Yes. So the three things what
Time
he
starts
said,
now.
he used the word havoc. I have 1.5 minutes left, Romila.
Yeah.
He used the word havoc. I think havoc was used as the practice-changing paper of this year. Havoc is synonymous with practice-changing paper. There is no doubt about that. No MRI. I completely agree. But without MRI in some patients, at the end of 5 years, all the curves are merging together. There's no separation at all. Yes, it is very important that it was a non-inferiority. It is, you want to omit one radiotherapy arm, which is considered one of the most important arm. You will start with non-inferiority. That is how you prove, and that is how you say that, okay, you can omit RT in some patients. Toxicity of FOLFOX long-term is not known, but toxicity of RT for 20 years data we know. So we have to choose the right patients, and we have to give them option today. Before this trial or before this data, I was not confident of omitting RT from any of my rectal cancer patients. Today, at least I am confident that I have a data where I can offer patient, especially young patients who are going to be sexually potent for many years, that look, you have this option of omitting RT. I'll stop here, Romila.
Yeah. Thank you so much, sir. Now, can we have the expert comment from Dr. Sanjeev Mishra, please?
Yeah. See, this is Dr. Sanjeev.
Yeah.
Thing is that I am a radiation oncologist, so I will have a bias. But I think
no issues, sir. You have your bias.
The conclusion what Dr. Vora said at the end, a specific group of patients. This is not for all patients, not for all locally advanced patients. Specific group of patients. If you look at T2 disease, maybe in stage 2 disease, you are telling that maybe adjuvant chemotherapy is not required. There is a debate just a half an hour back only. Then how can you give neoadjuvant in the same setting in the same group of patients? At the same time, if you have taken a very selected group of patients where the CRM-free patients are there, they are not involved in CRM. If you see the trial in detail in NEJM1. So that is the thing, definitely. But yes, there is a hope. Yeah, definitely there is a hope. We cannot say that no, every time radiation is required. But at the same time, every time chemotherapy is also not required. In stage 2, if you are not giving adjuvant, how can you give neoadjuvant? So I think that will be my answer.
Even Romila, you have given him some time. He has also saved some time. I would say radiation oncology is saying that there is a hope in some patients without radiation. I think that is enough for today.
It's enough for today. Thank you so much, sir. Thank you. It was a wonderful,
Thank you so much for
debate,
giving
and
me
we
this
saved
opportunity.
2.5 minutes. Nee, sir. Thank you so much. Pleasure is ours. Absolutely.
Thank you so much. Thank you.
So now we quickly shift towards our somehow the next talk. Dr. Avanish was unable to join, so we are not doing that. We straight over move to the panel discussion, and I would request Dr. Sanjeev Mishra to kindly take it up.
Yeah. Can I somebody put my slide? I have already sent, I think.
Anita, please set the slides.
Yeah, sure.
So it's like in other way, if you tell radiation mukt treatment. So radiation free treatment. So rectal cancer without radiation, it's really looks like very interesting. I think can I call my panelist, Dr. Sandeep Barik, Dr. Sunil Agarwal, Dr. Gautam Santosh Panda, and Dr. Saurabh Mishra.
Sir, you're not visible, sir.
I'm
Sanjeev,
not
sir, you're
visible.
not. No, you're not visible.
No, it's there.
Anita,
There's
can
some
we?
problem in your end, I think.
Yeah. Can we fix this, Anita?
Yes, I'm looking into it. Sir, your video is on, sir?
Yeah, it's on.
For us also, the screen is not.
Are we? I mean, like people who have switched on their videos, are they on? All of them? I mean, are they visible?
My video is
Like-
on from my side.
Yeah.
Sanjeev,
The
you
time
can
that we
start
had
now.
gave- Yeah, we can start. We can still start. Yeah.
Yeah, still we can start. Okay.
Yeah.
So I think all my panelists are there. No?
Yes, sir, they're there.
Dr.
I'm there. Others are there also.
Others are also there.
Yeah. So next slide, please.
Yeah, now you're visible, sir.
Oh. Yes. So let us come to a case-based discussion based on this paper only. It's a 28-year-old lady, no comorbidity, diagnosed with a case of CA lower rectum. Colonoscopy suggestive of a lower rectal growth 4 cm above the anal valves. Biopsy is adenocarcinoma. CT scan abdomen pelvis showed a small perirectal node with stranding. And on MRI, the mesorectal fossa is involved. No metastasis in PET CT scan. So basically, it is a CT3CN1M0. And what to do now? I would like to ask this thing to my medical oncology colleague first, because recently all the papers they showed there is benefit and all. Saurabh, please, what do you feel?
So Sanjeev, traditionally we would have gone for conventional chemo radiotherapy in such patients.
Yes.
Conventionally, that is what we would have done.
Yeah.
Now,
next slide, please. Next slide.
Yeah.
Then this is the MRI picture.
Okay. So the involvement of mesorectal fascia is something where I would like to incorporate radiotherapy in the treatment of these patients rather than just to go ahead with chemotherapy. So this is a high risk feature for any malignancy, rectal malignancy. So usually in the involvement of mesorectal fascia, probably concurrent chemoradiotherapy is what I would like to do.
But in the trial, actually, they have showed that you give neoadjuvant chemotherapy, even T3, all T3 they have taken. So T3D
Yes.
also, it is there. They have included all these patients. And in the, they gave neoadjuvant chemotherapy and then they operated it.
That is what I'm saying. So traditionally, this is what we would have done, CTRT. Now we have a positive result from one study, only one study, which is now showing that in proof of principle and also with a long follow-up, that probably in these patients, we can go ahead with chemotherapy only. And based on a response, we can incorporate radiotherapy. If there is a very good response, then we know chemotherapy, no radiotherapy. And if there is not a good response, incorporation radiotherapy. But this is one odd trial. Now,
So now I would like to ask my surgeon, Dr. Sunil, how comfortable you are if I am giving neoadjuvant radiotherapy to operate this case. Dr. Sunil Agarwal, our surgical oncologist.
Okay,
Is
sorry. So thank you very much. Actually, traditionally, what we are following is that we are following neoadjuvant chemoradiation followed by surgery. So we are totally accustomed with all those things. But here comes the catch in the sense treating a patient post neoadjuvant chemoradiation is having a lot of toxicity, and for a surgeon who is operating is definitely not that much of easy had it been the patient been treated by something else. In the sense, when even though we are quite sure about our anastomosis, due to the vascularity issue, we are doing a protective ileostomy. So that's a morbidity which we are giving.
What I would like to ask you, which one you will be more comfortable if somebody is having only chemotherapy or somebody is having CTRT?
So I haven't got any kind of practical experience. No patient has come up to me having a new
upfront, when we are doing upfront surgery, maybe 10 years back, 7 years back, we are doing upfront surgery.
I mean, upfront surgery, I have done only 2 patients, which are very small, but doing an upfront surgery, definitely it's much better than going after the chemoradiation.
So definitely post CTRT, the toxicity because of some fibrosis may be, but some surgeons said it's very easy to get the dissecting plane, so that if you are given radiotherapy, it is easier to take it out. I don't know what's your take on that.
No, I do feel like, yes, there are certain issues. If the tumor is quite a bulky one, if the tumor is T4, T3, something like that, definitely you cannot think of doing an upfront surgery. In that cases, yes, if you are doing giving a chemoradiation, definitely the field will be absolutely sterile and you can go ahead with a very well surgery kind of things. So it's all depend on what kind of patients you are dealing with.
Yeah, Dr. Sandeep, what do you like to do? Sandeep Barik,
Yes, sir.
radiation oncologist.
Good evening.
Good evening.
So actually, I'm traveling. Sorry for that. So I would definitely.
Yes. I think it's not audible. Probably there is some connection problem.
He's saying he will definitely travel.
We can't hear. Yeah. When
Are
he's
you not
traveling,
able to hear me?
Now you are audible, sir.
Yeah.
Yeah. So what prospect that trial design? They didn't have any PC. So
voice is cracking badly.
So Sandeep, just switch up your video. Switch up your video, Sandeep.
Just stop your video. I think the network will get better.
Better now?
Yeah.
Yes. So since we don't have a PCR rates in the prospect trial, I would rather subject this patient especially to long course chemoradiation and then ask for my surgical colleagues to operate.
Okay, so now it's like all the 3 branches they are telling in favor of their own treatment. It's fine. Next slide, please. So now if you see the CRM, you can see here this is the CRM that is positive already. It's a T3 tumor that has infiltrated that part. So that's the thing. Next, please. Next. Yeah. Yes. This is the one. So here in a T3 tumor, sometimes it is at least a 15 millimeter from the muscular layer. Maybe it has gone to the CRM and infected the CRM. That's the major that's the major problem. If you give chemotherapy, maybe it will recede. If you give radiotherapy, again it will recede. Now come to the actual trial, what they have done. Next, please. Next slide. Yeah. Previous one. Yes. You can see in this trial, the prospect study, they have taken CT3, N1, N plus, and N minus, and CT2. So they have taken T1, T2 tumor, T2 and T3 tumor, node positive or negative tumor, and they have given neoadjuvant chemotherapy followed by radiotherapy. So T3 tumor they have involved, they have taken as this thing. And at the same time, now the opinions for this type of tumor, you cannot do a upfront surgery definitely because already the CRM is involved. And at the same time, if you are giving a local therapy, radiotherapy, it's okay, fine, toxicity will be there. But on the other hand, if you give chemotherapy, how far it is controlling this tumor, especially when there is a CRM positivity is there, that's very important, because one of the indication giving adjuvant radiotherapy is a node positivity, and obviously CRM positivity definitely a indication for radiation. So that is what still there is no clear-cut thing in this paper. Next, please. Next, please. Next slide. Yes. So what happened? If you look at the whole of the paper by in the NEJM and the prospect trial, the non-responders, those who did not respond to FOLFOX or those who could not complete 5 cycles of chemotherapy, or the regression is less than 20%, there has been switch over to the CTRTR. And all the patients, what they have taken are all CRM negative. That is what I was telling to Dr. Saurav. This is CRM positive. But the patient, what they have taken, almost all the patients, they are all CRM negative patient. And T4 patient, they have taken out. They have withdrawn from the trial. They have not included in the trial. 4 or more node positive, they have excluded from the trial. Or any node more than 1 centimeter, or visible tumor within 3 millimeter from the radial margin, they have excluded from the study. So that is what I told you. Don't take all locally advanced as like T3 tumor with T3D. No. They have taken all the resectable tumor, T2 up to T3B or C, sometimes like that. So all are CRM negative. So that is the reason why they got all R0 resection, even with chemotherapy. And at the same time, if you see low-lying disease, the number of low-lying disease in these trials are really very less. And that is why they were able to do 98% LAR. That's very interesting thing. APR, they have done hardly 2% only in both the arms. So they have not taken the low-lying disease where there is a chances of local failure is more. So that's why they give chemotherapy and radiotherapy. That didn't make any difference. And post-FOLFOX, post neoadjuvant chemotherapy, if you are there getting a R1 resection, then again 9% of the patients were given RT of these patients. So that is why in one arm, the chemotherapy arm, if you see, they are all selected patients, those who are responders. Those who did not respond or could not complete because of low GC, they switch over to the CTRTR. So, or those who could not complete, they switch over to CTRTR. So that is why it is a selected group of patients. That's why I told Dr. Bhora's presentation, they are in selected patient group. T1, T2, T3, B, not beyond that. Not D.
So Sanjay, many of these patients actually would not qualify for routine CTRT even in clinical practice, right?
See, so just I will tell you, if somebody cannot tolerate 5 cycle of FOLFOX, and that patient you are switching over to CTRTR, how they tolerate CTRT? Somebody who could not tolerate FOLFOX, you are putting the same patient into CTRT. How they will tolerate?
I am not telling that. I am saying that these were so good risk patients. All these patients were included in this positive prospect study. They were all so good risk patients that many of them would not require CTRT actually upfront.
Yeah, that's what I told you. They are selected group of patient actually. They are selected group of patient.
Because we have another study where clearly it was shown that in genuinely patients who require CTRT, if you randomize them to neoadjuvant chemotherapy versus CTRT, you cannot show non-inferiority.
Exactly.
This was what was again, it was also present.
Exactly. Yeah. That's what, next slide please. That's what I will show you the other one. Now you can see in this patient like a 38-year-old lady, obviously needs a sphincter preservation. We may not be needing a colostomy bag. 1 to 2 millimeter fat plan between you can see here there is a good flat plan only, but disease is still there. And lower rectal cancer and the sphincter complex, this you can see the arrow here. And the circumferential margin of resection may be considered free. Technically, it is free. What you would like to do? Dr. Dr. Agarwal, Dr. Sunil. It's a low rectal disease, T3, and at the same time, the CRM is negative, but it is really very close to the sphincter.
So definitely in this patient, I presume that the neoadjuvant chemoradiation has
Exactly. Now, if you are telling neoadjuvant
given to this
chemoradiation
patient,
in this
and
patient is
sphincter
really
preserving
very
surgery.
good and helpful.
Yes.
But look at the trial, what the trial is telling. In the trial, actually, they are telling no, T3 tumor, you can give CTRT, but at the same time, they have excluded the low-lying disease. The low-lying disease percentage is very less in comparison to higher disease. And that is why they were able to do LAR in 98% of the patients. So that is what I would like to say. Probably you need to have like this paper is fine, neoadjuvant chemotherapy is fine, but really in a selected group of patients. Next, please. Now come to the third case, the same scenario. It's a T4B
So 5 more
disease.
minutes.
Yeah, it's a T4B disease. What to do now? Dr. Sunil.
T4B disease means?
Means there is
Yes,
definitely, it has come out of the serosa and involved some organ outside.
Correct. So definitely this patient is, again, definitely it will be going for a neoadjuvant chemoradiation.
CTRT. You cannot give chemotherapy only in this patient
There
because
is
they
no
have taken
doubt
out the
about
T4-1
as per the
from the trial.
present.
Yeah, they have taken out T4
I'm completely agree.
cases in the trial.
I'm completely agree with
Next,
you.
please. Yeah. So now you see the convert trial. Convert trial, I will show you the neoadjuvant CTRT has been questioned due to inevitable toxicity. I was talking about the toxicity, but at the same time, toxicity is like maybe those surgeons who are used to do with this post CTRT patient, maybe they don't bother whether it is upfront or post CTRT, but still it's okay, fine. If the literature says the toxicity with CTRT is there, fine, you can take it like that. Now, the other is that all the patients are uninvolved major rectal fossa. That's a very important thing. Next, please. Next, please. Yeah. No, just go back. In this trial, also you can see they have given 4-cycle capox in the randomized 1:1, 650 patient. After giving 4-cycle capox, those who are having progressive disease, they are putting the same patient into CTRTR. So after the failure of chemotherapy, they are putting the same into, though the numbers are very less. Next, please. Number you can see here. Yeah, only 4 patients received salvage neoadjuvant CTRT before local disease progression. Next, please. Next, please. Yeah. And also in the prospect trial, you can see 9.1% patient, those who did not respond or that did not tolerate chemotherapy were switched over to the CTRTR. That is one of the really problematic thing in the statistic. Next, please. And also they showed everything fine, but 3-year local regional recurrence-free survival. Local regional recurrence-free survival, still the CTRT is bit superior. We cannot say. Though the DFS and the overall survival is same, but 3-year local regional recurrence-free survival, still the CTRT is bit superior. Next, please. So that's why what they concluded is the non-inferiority of neoadjuvant CT not confirming 3-year local regional free survival, and neoadjuvant chemotherapy could serve as the alternative to neoadjuvant CTRT in local administration in an uninvolved MRF. Mesorectal fossa is not involved, then only you can put it in the neoadjuvant CT, maybe an alternate. So that's why in a selected group of patients. Next, please. Next, please. Next. I think, thank you very much. Yeah. So that's why to conclude, definitely it is good for a subgroup of patient, those who can be really, radiation can be avoided, toxicity can be avoided, not for all patients of locally advanced rectal cancer.
That was a good take. It has to be individualized. And thank you very much, sir. Thank you. It was really informative.
I just
Thank
want
you.
I just want to say, sir, the last word. Sanjay bhai, you have pointed out correctly. Had it been the trial would have taken a T3, T4 tumor, the lower rectal tumor, and done this one, and you can see when you study this trial is unblinded trial. This is not a blinded trial.
Excuse me.
So definitely the bias will come into the picture, and had it been the other way around, then probably it would have been a much better one. But definitely chemotherapy, this TNT is there, so definitely chemotherapy is coming have a more role. The long-term result of German trial has come up, so that shows that chemotherapy has got better. Thing, because what we are giving in chemo radiation is only the sensitizing one. So absolutely fantastically, you have pointed it out, like what is the fallacy in this one, and it's a very good take-home message. Thank you very much.
Thank you.
Thank
Thank
you.
you very much, sir. Thank you. So before proceeding to the next session of the biliary tract tumors, we have the quiz results. I hope the participants who have won are there. For question number 1, it is Mr. Sushant Kumar. For question number 2, it was Dr. Chandrakant. And also again for question number 3, Dr. M.V. Chandrakant. Unfortunately, Nargis wala question, nobody came up with the correct answers. So we don't have a winner for question number 4. And for question number 5, it's Dr. Dinesh Kumar. So can we please clap for all of them? And I hope they are there listening us out. And now we quickly shift to the biliary tumors, and it would be taken up by Dr. Joydeep Ghosh from Kolkata, medical oncologist from Kolkata. Over to you, Dr. Ghosh. We did have him with us. He was, I could see him in the participant list.
Yeah, I am there. I'm there. I'll just.
Dr. Moderator for this entire session is Dr. Joydeep Ghosh.
Yeah.
And yeah, the first speaker is Dr. Sandeep Ganguly, indeed, no doubt. Yeah. So for the next speaker on the topic newer updates in the management of first-line biliary tract cancers, it is Dr. Sandeep Ganguly. Yeah, he's already. Thank you.
So I think my slides are visible.
Yes,
thank
they
you,
are.
Ghansham sir. Thank you, Ghansham sir, for the welcoming us from IAO for this extravagant gastrointestinal topic of the day. It was excellent sessions by the people about the rectal cancer, interesting point. So we will go to the updates in the management of first-line biliary tract malignancy. We all know that the biliary cancer is quite common in India, and they are more common in the north and the eastern part of the India. The 90% of the biliary tract cancers are diagnosed in the unresectable of the advanced stage. And patients treated with the current standard of care, which is gemcitabine cisplatin, have a median OS of only less than 1 year, with a 5-year OS rate of less than 10%. So obviously there is an unmet need for the managed to improve the outcome of patients with metastatic biliary tract malignancy. And this trial was done when we were in the, I think, just before entering DM in 2010, gemcitabine plus cisplatin was established as a standard first-line chemotherapy. The ABC02 study, where the median OS was 11 months versus 8.1 months, and the median PFS was 8 to 5 months with the control with gemcitabine arm. So it was statistically significant, and this became the standard of care. There was a study, initially one study was done by Dr. Amit Doari from AIMS, where the GEMOX showed some improved response. And based on that, there is a TMH study where they tried to compare GemCis versus gemcitabine oxaliplatin, match pair analysis. Here they found that the response rate is more or less equal, like around 30%. With a median event-free survival is numerically better in the GemCis arm, and even the median OS is just numerically better. And so they say that in first time, some patients, because of the patients who are very elderly, who have a deranged CKD, underlying CKD, we can use GEMOX for those group of patients, and the toxicity profile is also different. Lower incidence of hematological toxicities, and potentially because you do not have to hydrate the patient. So patients with borderline renal and cardiac functions, we can use GEMOX, but again, the response is quite pretty modest. And NCCN in 2022, before the pre-IO era, it was only the GemCis only. But then the immunotherapy came in the first line advanced biliary tract cancer. This is the Topaz study, where I think our moderator, Dr. Joydeep, was also one of the PI from the country. A phase 3 randomized double-blind placebo-controlled study of durvalumab in combination with gemcitabine cisplatin. And the study design was locally advanced or metastatic biliary tract cancer, more than 6 months recurrent, our disease-free interval from curative surgery. Baseline serum bilirubin less than 2, PS1, 0 to 1, more than 1 measurable lesion. And they were randomized to receive either Durva Gemcis or Gemcis alone. And durvalumab here was given maintenance every 4 weekly, while in the Gemcis arm, there was no maintenance therapy. The primary endpoint was OS. The key secondary endpoint was PFS, response rate, duration of response, quality of life, biomarker, pharmacokinetic study. The baseline characteristics of the patients were more or less equal. The majority were females, it was 50%. Majority were Asian, but it was mainly from the Chinese. And the majority had intrahepatic cholangio, and only gallbladder was only 24%, and majority had initially unresectable disease. And the MSI was high, was only seen in 0.9%. And PD-L1 expression was missing in 12%, and majority of the patients, however, had 57% of the patients had a high PD-L1 expression. Patient disposition, 99% of the patients received treatment. When the study was published, ongoing treatment was continued in 18.6% in the Durva arm, while only 5% in the placebo arm. And majority of the patients who had discontinued was because of the radiological disease progression. It was 56-69%. AE-related this thing was only seen in less than 6% of the patients. And this is subsequent anti-therapies. Around nearly 50% of the patients received anti-cancer therapies in the second line. And the immunotherapy was given only in 4% of the patients in the second line setting. Those who have received placebo. And Imfinzi plus GemCis was the first and only approved IO, which shows a 2 years sustained and durable OS. This Kaplan-Meier graph, the median OS was 12.9 versus 11.3 months, 1.6 months absolute benefit. The hazard ratio was 0.76, which was statistically significant. But one thing to note that after 6 months, the curve starts separating. And those who respond, they really respond for a long period of time. Around 2-year OS is 24% in the IO arm compared to 11.5% in the GemCis arm. So this was quite remarkable. And forest plot shows that almost all the patients, all the subgroups have benefited from the addition of durvalumab to GemCis. And also there's the improvement in the median PFS. It was 7.2 versus 5.7 months. And the 12-month PFS is 16 versus 6, which is quite remarkable. And the hazard ratio was 0.75. Again, it was statistically significant. And again, the PFS forest plot shows that almost all the subgroups have derived the benefit from addition of durvalumab. And response, the overall response rate is around 26% in the GemCis arm, while it was 18.7% in the non-IO arm. And more than 12, the patients who have a continued response, more than 12% months response was seen in around 26% of the patients in the Durva arm compared to only 15%. And the duration of also response is pretty high. Like those who respond, they keep on responding for a long period of time. And among responders, there was obviously a clear-cut and sustained separation, as I have said, that those who have beginning approximately 15 months after randomization. And so if a patient keeps on responding, they will respond for a more prolonged period of time. Coming to the AEs, any AEs or serious AEs occurred in 99 and 47.53 patients respectively in the Durva GemCis arm. However, discontinuation leading to the discontinuation occurred only in 8.9% of the patients in the Durva arm, and leading to death occurred only in 0.6%, so it is a very well tolerated. And immune-mediated AEs, any grade 3 immune-mediated AEs occurred only in 2.4% of the patients. So this shows that the drug is not only has a good response rate, but also is very well tolerated by the patient. And most of the AEs are related to the chemotherapy component, which was there in the Durva arm, and they were easily manageable.
Dr. Sandeep, we have last 2 minutes.
Yeah. And the safety and toxicity again is there, and again the grade 3 AEs are quite less, and OS, those who have there is no found that the OS benefit is there irrespective of the immune-mediated AE occurred or not. And NCCN guidelines have shown that the durvalumab has given a category 1 recommendation in primary treatment for unresectable and metastatic gallbladder cancer. So 2010 GEMSIS, then in between they tried to show a GEMSIS Durva plus minus tremelimumab, but then ultimately after 13 years, Durva plus GEMSIS. And I think there is OS benefit, safety, DCGI approval is there. And with this, I will finish and give the podium to the organizer. Thank you.
Thank you. Thank you for finishing on time. So, Dr. Jaideep Ghosh, can we take up with the panel discussion?
Yes, I'll just share the screen.
Okay. Thank you.
I'll just call my panelists. I hope the slides are visible.
Slides are visible, yes.
Okay, so I'd like to call upon my panelists, Dr. Sandeep Ganguly, Dr. Prashant Parida, Dr. Ghanshyam Biswas, and Dr. Shoman Roy. Dr. Shoman Roy is from GI surgery background, and rest all my panelists are medical oncologists. So as we would understand that the role of surgery as such is limited in advanced biliary cancers. So I'd like to start off right at the beginning with Dr. Shoman Roy. When do you call a biliary tract cancer as unresectable? Say, for example, for gallbladder cancer, what are the things that you need to you look for considering unresectability in gallbladder cancer?
So, sir, just to start with, we know everybody that that advanced biliary cancers are very likely to be unresectable. For gallbladder cancer to be unresectable in this current era of HPV and liver transplant, actually, if it involves contralateral left hepatic artery, I am just not talking about metastatic unresectability. If gallbladder cancer is involving the left hepatic artery and portal vein, we ideally avoid, as SPV surgeons, we avoid operating. Involving liver, lymph nodes, localized, hilum, even right hepatic artery involvement also can be resected with R0 resection. But those are very similar, very rare cases. Okay. So those unresectability criteria have developed over the last decade, basically. Those cases who were unresectable previously 5 years back, now they are resectable because of the advancement of the interventions and the especially neoadjuvant chemotherapy area.
Oh, thank you, Dr. Roy. So let us move ahead. So this is this basics have already been discussed by Dr. Sandeep Ganguly, so I'm not going to the details. Let us come directly to the questions. So Dr. Sandeep, how is your caseload in your practice, approximate number of patients that you see in biliary tract cancers?
Around 20 per month.
20 per month. Okay. Dr. Prashant Parida, amongst the biliary tract cancers, which is more common in your practice, cholangio or gallbladder?
Yes, so I see more gallbladder than cholangiocarcinoma. So just like what we have seen in ganglionic belt, so I see more gallbladder than cholangio.
Okay. And Ghanshyam, regarding the resectability, how do you see your patients? I mean, how many of them actually come to you in the resectable state?
So maybe 2 or 3 out of 10. So probably the only thing is that these days we see more men than the female. So this trend is also changing. So the traditional teaching that gallbladder calculi, gallbladder malignancies were common. So that is also a trending change in trend also.
So in our hospital, we have a very proactive HPV team. So we sometimes get patients for a trial neoadjuvant chemotherapy. In your practice, do you get such cases where they call it as borderline resectable? There is a concept of borderline resectable.
Absolutely, absolutely.
Yeah. So, normally, Dr. Shoman Roy, normally, what is your patient journey like in when it comes? Does it see you first, or does it see the medical oncologist first? How does it go?
Basically, it's actually varies. I will say if I break it up, gallbladder malignancies involving liver, those are mainly referred from the medical oncologist after neoadjuvant. What I am seeing last current few years. Gallbladder cancer involving neck, involving jaundice, causing jaundice, hilar block. Those are referred from the gastroenterologist when they are detected after ERCP stenting or somewhere down the line. And direct intrahepatic cholangio or periampullary, those are direct, we can get direct cases sometimes. But most commonly, gallbladder cancers are common in our area. So somewhere directly or somewhere from the oncologist, medical oncologist.
Okay, so Sandeep, do you agree that MDT is important in the biliary tract cancer management regarding plan of action?
Yes, it is important, but the surgeon should be practical. It should not be some anecdotal cases, should not give the surgeon the false hope that everyone will be operable. But yes, it is important.
True. So, role of a hepatologist in the biliary tract management, Dr. Prashant, do you routinely involve a gastroenterologist or a hepatologist in the biliary tract management?
So though I may not be able to involve always, but it is very important to involve a hepatologist or gastroenterologist, especially for assessing the resectability, as well as sometimes patient presenting with obstructive jaundice, they have a role of doing ERCP or stenting, sometimes taking biopsy from them also. So it is very important to involve a hepatologist or
But
gastroenterologist.
resectability is largely decided by the surgeon, right? If I'm not
Yes,
wrong.
yes. But assessing the functional liver reserve, FLR,
That is
also
very
important.
important. Yes, that is very important. So these are the basic diagnostic and staging investigations. I think this is a very learned crowd. We can actually go into the details. So, Dr. Ghansham, any molecular testing that you routinely do in your set of patients?
So I normally do three things. That is, one is HER2/neu, one is MSI, and one is PDL1. But after the Topaz one, I thought that probably so for a patient who may not be able to do so only an HER2/neu, because Topaz showed that so irrespective of PDL1,
yes,
they are going to benefit. So at
and
least
in your practice, have you ever come across an IDH1 or an FGFR mutation?
so IDH1 definitely. So I come across, but we haven't looked at this treatment. But quite a few HER2 positive tumors, and at least a couple of patients with a high CPS of 10 or also I've encountered, but they haven't been treated differently.
Okay. Recently, there was a publication from TMH by Anand and Dr. Vikas Oswal regarding the combination of trastuzumab with Gemcis as the first-line treatment. So that is one good Indian data that we have now for HER2. So Sandeep, in your practice, any patients with FGFR or IDH or any other rare or weird mutation other than HER2?
I had one IDH and FGFR, but none of them could afford the targeted therapy.
Okay, yeah, that's obvious. So as you can see here that HER2 is quite common in gallbladder and 16%. And if you look at the FGFR, that is more common in the intrahepatic cholangio. And the IDH mutations also, they are more common in the intrahepatic cholangio. I think this data is primarily because this is data from the West, where gallbladder is rare and intrahepatic cholangio is more common. I think if we have a sequencing studies done in India, the picture will be slightly different from what is presented here. So these are the ESMO recommendations. I'll not go into the details. So coming to the treatment plan, as we all know that we need to take the help of the surgical colleagues regarding the resectability. If it is early stage, definitely surgery is the treatment. If it is locally advanced, unresectable or borderline resectable, we go for either a trial of systemic neoadjuvant chemotherapy plus minus IO. And if it is advanced, of course, we go for molecular profiling. And if it is all negative, we go for GEM-CIS Durva or GEM-CIS Pembro. In fact, now the data is there. For IDH, we have the ivosidenib. For FGFR fusion, we have pemigatinib, infigratinib, and futibatinib. And also BRAF, MSI, these are all the molecular targets that can be targeted with therapy. This is more or less the same. So coming to our surgeon, Dr. Showman. So if you are to select between a surgery or a transplant in a biliary tract cancer, what would you select, and why would that be?
See, still currently, since I am into liver transplant, we are attending, and lot of data are coming since 1993, the Mayo protocol. Still in our transplant group, Pan India, where LDLT are very famous, nobody advises for transplant in cholangiocarcinoma.
Right.
It may be gallbladder, leave it, forget it. Hilar in intrahepatic cholangiocarcinoma, there are data, case series are coming up from Western and Eastern zone, but still it is because of the low survival rate and the high recurrence rate, transplant is now not the standard of care. So
Right.
surgery is the standard of care currently in biliary tract cancers, no doubt about it.
Right. And so if you just incidentally pick up a cholangio which is very small, it will be difficult to achieve an R0 resection, maybe because of the proximity to major structures. In that situation, would you recommend going for a TACE or tear followed by transplant?
Yeah, I will tell that in Medanta group they have published data in Gurugram in transplant intrahepatic cholangio, and Chennai group they are publishing around 50 odd cases. They have downstage, but along with neoadjuvant, GEM-CIS or GEM-CAP, along with TARE. So they are very short reports. These kind of reports are coming up, especially in case of intrahepatic cholangio and hilar cholangio come down the list. These are the two cases where transplants things are going on. But still, standard of care is surgical resection, not liver transplant.
I completely agree with you. So coming to adjuvant treatment, we all know medical oncologists that capecitabine is the only thing that has proven to be beneficial, of course, in the PAR protocol analysis and not in the intention to treat. Although the trial initially, the primary endpoint was basically overall survival in both intention to treat as well as PAR protocol. So that way we can consider one of the endpoints was met. But yes, in the intention to treat, it was not statistically significant. And also many other groups have actually tried other regimens like GEM-CIS, GEM-OXALI compared to observation alone. None of them actually led to any positive results. So as of now, the standard of care for adjuvant is capecitabine. So coming to the role of NSCT, this was again a publication from TMH, where they analyzed 160 cases of GBCA received NSCT based on clinical radiological criteria, followed by surgery or no surgery done. Obviously, those who underwent surgery, that means the good responders, once they had a better survival compared to those who did not undergo surgery. So NSCT is definitely feasible, doable, and it is picking up in recent times, especially in clear-cut borderline cases. Role of loco-regional therapy, Sandeep, do you promote loco-regional therapy like TACE, TARE, or RFA in cholangio?
Actually, most of the patients present with so much advanced disease that they do not get the opportunity to get locally directed therapy.
Yeah. So I'll just share one experience. There was one intrahepatic cholangio mother of a cardiologist from US. GEM-CIS durvalumab was given post three cycles. There was no response. They went to one of the centers in South and underwent proton beam therapy and came back. and there was progressive disease within 2 months. So that's it. So now coming to the preferred choice of therapy, Ghanshyam sir, what is your regimen of choice for keeping aside finances? I'm sure it will be Gemcitabine durvalumab now.
So GEM Platinum, so you'll always, because GEM Cis has been the backbone. So you look at cisplatin eligibility. If not, then probably either you choose oxaliplatin or capecitabine, and definitely, so somebody who can afford it, durvalumab with the topaz-1.
Right. So for a very long time, basically gemcitabine was the standard of care. Then came the GemCis, which showed better survival compared to GM alone. Also, this is the study shown by Dr. Sandeep regarding the GEMOX versus GemCis by match pair analysis by Dr. Anand Ramaswamy. There also it showed that more or less comparable outcomes. And this is the AIMS study, randomized trial by Dr. Dwadi and Atul Sharma. Here also there was no difference between the regimens. People tried to add one more drug, so basically a triplet regimen. In the initial phase 2 study, it was quite exciting. Many people changed their practice right away, looking at the response rate. But when this was confirmed in a phase 3 randomized trial, it was found that it did not achieve any meaningful improvement in the overall survival. So no role of any triplet regimen for advanced gallbladder cancer. S1 is gaining importance in recent times. This data which was presented in ESMO 2018. It showed numerically better as well as in statistically significant improvement in PFS and OS when S1 was added to GEM plus Cis rather than GEM Cis alone. So, Prashant, do you normally give maintenance gemcitabine for your patients who are responders?
No.
No.
I
So you end at 6 to 8
usually
cycles. Okay. Anybody following any maintenance therapy? Sandeep?
I follow. So somebody on a GEM Cis or a GEM oxaliplatin, so post 6 cycles or 8 cycles. So I continue them on day 1/8 or day 1/15 of gemcitabine. So
Till progression. Okay. Sandeep, what is your take on this? Sandeep? Okay, I think we've lost him. So this is some small scale data regarding maintenance, and it shows that maintenance contributes to increase in the PFS. Here, this is again real world evidence which shows that a group of patients whose survival could be prolonged by continuing chemotherapy. So the take home message would be that if you have a very good responder and who is tolerating the chemotherapy quite well, you might continue the chemotherapy, or you may stop at 6 to 8 cycles after a discussion. Role of IO, definitely role of IO has been proven beyond doubt. So, Ghanshyam sir, what is your experience with IO in biliary tract cancers? We all know the Topaz-1 data.
I have a patient who has a cholangiocarcinoma, really. So because you have been a part of this, so out of 4 PI, so I think, so if you look at the data also, so probably cholangios have been a better responder, but unfortunately we see more of a gallbladder cancers. But still, we'll have the patient who is affording, so definitely we'll put them on this.
Right. So this was the trial design. I'm not going to the discussion of the baseline. So basically, it led to a significant improvement in the overall survival. It was for the median OS was 12.9 versus 11.3 months. Although the magnitude of OS difference was not that great, but we need to understand that these are very poor poor prognosis malignancies. So we don't expect a very dramatic improvement in the OS. And also the subgroup analysis more or less shows good response to durvalumab. And this is the analysis which shows that patients who had a good response that we were talking of recently, that CR or PR, they tend to have a better survival compared to the poor responders, I think, which is quite obvious. And this is again the PFS data, which is statistically significant. Here also the subgroups showed benefit. And also there is increased response rate. Now, why this is important is that if you are getting a locally advanced cancer where the surgeon feels that if there is a very good response, then he can go for surgery. In that situation, he might combine durvalumab plus gemcitabine to achieve that 10% improvement in the response rate. So I think toxicity, safety, more or less, it's for medical oncologists, it's just the same. Most of the toxicities has been hypothyroidism and dermatitis, as per the trial data that I'm saying, and also in personal experience, mostly it has been hypothyroidism, dermatitis, and fatigue. Not much of a colitis or autoimmune hepatitis. So I think this question is more or less same answer, all of us. We would be definitely looking at the PFS and the OS, and then comes the response rate and AE profile. So I think we have discussed overall the management of biliary tract cancers, and definitely
5 minutes, sir. 5 more minutes.
Yeah. So IO plus chemo is the way forward. And in the IO area, the first trial to come was durvalumab, and now we also have the combination of pembrolizumab. And also people are looking at combinations of IO plus other molecules based on the molecular profiling. Also the role of IO in the second line. So I think exciting times are yet to come in this area. So I wish to conclude with that. Thank you.
Thank you so much. It was informative indeed. But then again, biliary tract cancers overall have such poor prognosis. More studies and much more to come in future, hopefully. So there's a slight change. We'll take up the quiz now, which would be conducted by Dr. Garima Saraugi, surgical oncologist from Bhubaneswar. All over to you, Dr. Garima.
Hello, ma'am. Good evening, ma'am.
Yeah.
Do I have timer, ma'am?
Sorry? Come again?
Timer, ma'am, for the quiz?
Timer, I
Yes,
don't think
timer is there for each question. We will be having like 30 seconds.
Yeah, 30 seconds for it. I think it will appear on the screen, right? That is what she's asking.
Yes, it will appear on the screen.
Absolutely. Perfect. Go ahead, Dr. Garima.
So thank you so much for the brilliant session so far. And thank you so much, Ghanshyam sir, for the opportunity. I'll go ahead with the quiz. My first question is, colon cancer stage 2. Which of the following criteria is a high risk indicative factor for considering adjuvant chemotherapy? So this has been discussed in details by Amish sir, by Shifali ma'am, everybody. Could you please start the timer? High risk indicative factor for considering adjuvant chemotherapy. Yes. 3 more seconds to go. Time's up. Next slide, please. So the answer is grade BD3 tumor budding. It is not proficient MMR or MSS. As they have been discussing about the circulating tumor cells, grade 3 tumor budding is the criteria. The next slide, please. So the ASCO study, this is the published patients with high-risk features. We all know all the other criteria, which is sampling of less than 12 lymph nodes, perineural or lymphatic invasion, poorly differentiated tumor, intestinal obstruction, not an impending obstruction here, tumor perforation, and grade 3 tumor budding, which increases the circulating tumor cells and hence the chances of MDR. That's why that's the answer. Next question, please. An intergroup phase 3 trial of ramucirumab plus irinotecan in the third or more line beyond progression after ramucirumab for adjuvant for advanced gastric cancer with primary outcome of overall survival benefit. This trial has been discussed today. Please switch on the timer. This trial was done in which country?
Dr. Garima, when you say the answer, so you say final answer A, B, or C, so that the volunteers can put the right answer, so they can check it.
Okay, sir. Okay, sir.
So after all explanation, so you can answer that the B is the right answer or the C is the right answer.
Correct, sir. 3 more seconds to go. Mostly everybody is correct, put the correct answer. Next slide, please. So this is the Rinberg trial that has been discussed today in our sessions. It was conducted in B, Japan. Japan is the right answer. Next slide, please. So Rinberg trial has been already discussed in details. Next slide, please. Question 3. A 60-year-old man presented with a solid expansive lesion 3 into 2.8 centimeters in the body of pancreas, where 50% involvement of the celiac trunk at the level of its bifurcation was there. Peripancreatic lymph nodes on imaging was seen. Clinical staging was T3, T4, N1, M0 disease. After neoadjuvant chemotherapy, there was a small reduction of the tumor, but an important decreasing of the celiac trunk involvement by 25% was there in imaging. He underwent robotic surgical resection. Identify the surgery in image. I have not given options here. I need the answer in word. Timer, please. Next option. Next slide, please. The image. This is a surgical image of the tumor and a 3D image after resection of the tumor. Which is this surgical procedure? It is in the body. We can see the celiac trunk is involved. Anybody? So the body and celiac trunk after neoadjuvant chemotherapy. Nobody has got the answer right that I could see till now. I cannot see the timer.
30 seconds time is up, ma'am.
Okay, the time is up. So we'll go ahead with the answer. The correct answer is, next slide, please. This is Appleby procedure, which is distal pancreatectomy along with celiac axis resection. So 2 interesting things here. Unlike Whipple's procedure, this is not Whipple's procedure because the celiac trunk itself was involved. And the common hepatic artery, left gastric artery and the splenic artery that is involved by the tumor has to be resected surgically with margins. So in the second image, we can see the clips that is placed in the CT angio. Interestingly here, there is no anastomosis unlike Whipple's procedure. This encompasses distal pancreatectomy along with celiac axis resection alone. Here, splenectomy is done along with the procedure. So the liver, because the common hepatic artery is resected out, liver interestingly gets its supply as shown in the first image by a collateral circulation from SMA retrogressively through the GDA and through the proper hepatic artery. The answer is Appleby procedure. Anybody who got that is correct. Next slide, please. The fourth question, which of the following is categorized as group 1 carcinogen in IARC carcinogen classification for GI malignancies? Red lamb meat, beef meat, pork, or bacon? Timer, please. So category 1 carcinogen I'm talking about. All of them are red meat. So lamb meat, beef meat, both are red meat as such.
Time is up. Yeah.
Answer for this is D, bacon. D is the correct answer. Next slide, please. All the other 3 options, all of them are group 2A classified red meat carcinogens. So a processed meat, which is usually salami, bacon, or sausages, they are category 1 group A, highest risk which causes cancer definitely. The other red meats, as most people have told here, is actually categorized as group 2A. It is D, answer bacon. The next question is, which cancer took them away? This question has part A and part B. So I want to know which pathological variety of the cancer. The second, next slide, please. So both of them were diagnosed with the timer, please. Both of them were diagnosed with the same organs as everybody is answering. I am asking for the pathological variant for A and B. You can answer as A for the first person, B for the second person. Yeah, Steve Jobs also had the same organ involved, and Irfan Khan, of course. So both had different cancers, not the same one, by the way. Yeah, time's up. So next slide, please. So the answer is in Irfan Khan, as most of the people here have told, pancreatic neuroendocrine cancer. But Steve Jobs did not have a neuroendocrine alone. He had a pancreatic adenocarcinoma. So we can let the judges decide. Most of the people have answered pancreatic and neuroendocrine only. Thank you so much, Romila ma'am. Thank you so much, Ghanshyam sir. Quiz is over.
Thank you. Thank you so much, Dr. Garima. It was very interesting and presented in a wonderful way. So we announced the winners a little later after the last session, the concluding session of this day one of the IAO second oncology updates. We have Dr. Ghanshyam Biswas, who would be speaking on optimizing the results with ferric carboxymaltose, commonly known as NC-carb, thanks to Impure to sponsor this, in iron deficiency anemia. Over to you, sir. Thank you.
So that was a great questions from Dr. Garima. So thank you, Romila. So, and thank you, Impure, for sponsoring this session. So day one, last session. So FCM in iron deficiency anemia. So being in the oncology forum, so let's see and focus on the oncology front. So this has been the US FDA approval timelines from since yesteryears of how ferrous ferric iron, and then came the era of we can see a parenteral iron, which used to be a muscular, intramuscular, and then came the intravenous first time in 2013, and later on in 2020 was the iron isomaltoside. So the first generation is iron dextron, so which have been into the pen of most of our gynecological friends. So the JED technique was used. And second generation, many of us have used this. Those are ferric gluconate iron sucrose, or rather we can say iron sucrose. And then the third generation, which is probably last few years, and with the availability of recently the patent being off, and I think the market is flooded with varieties of FCM, so which is to be costly at some point of time. So a month back or so it has become cheaper. So in third generation, we have two products. So one is ferric carboxymaltose, which is FCM, and the other one is iron isomaltoside. So the first generation, the dextran formulation, so we have seen a rare but serious allergic reactions, and that's why many of us will be avoiding in house-based, unless not in the hospitals, even in a remote village. And it is usually intramuscular, and we do understand that intramuscular iron preparations were very painful. And the second generation iron sucrose, so the iron part is quite labile, and you have to give quite a frequent dosing. And we have seen many of our gynecological friends during the during pregnancy, they receive this. But most of the oncology population, and then again, so our gynecological friend and even nephrology friends have moved into a FCM, and still some of us use the iron isomaltoside. So I think so these are two formulations which are being used by these patentee people. So unique, strong, complex structure releasing much lower levels of labile or free iron, and allowing large dose of iron to be given on a shorter time period. So in short, iron dextran intramuscular risk of anaphylaxis is there. So in times of medical legal cases, should be rest be assured that so you don't land up in a problem. Iron sucrose, multiple doses, longer time of administration, so 2 hours, 3 hours, 4 hours. And then we have moved into a new era or new age of IV iron. This is FCM and iron isomaltoside. So ferric carboxymaltose or FCM has a high amount of iron in a single dose. So we can give up to 1000 to 1500 with a low risk of HSR, that is hypersensitivity reaction. Iron isomaltose, again, we can give on a higher dose, but more level iron than the FCM, but because still it has a reduced amount of dextran. And probably the scientific literatures are less as compared to FCM today. So this is comparison of the second generation and first generation, second generation, third generation. So what is to be more focused in the third generation is that this is a half-life of 60 hours as compared to very small 6 hours in iron sucrose. The important is that you don't require a test dose of FCM. And another important is that the time of injection. So for 1000 milligrams, so you can get away with 15 minutes in a 250 ml NS. So now, so coming to a summary of what FCM does is type 1 robust parenteral iron, not associated with dextran-induced hypersensitivity, can be administered in much higher doses, 15 minutes over in 1000 milligram, short infusion time. Iron is released slowly, avoiding toxicity and oxidative stress. Structure similar to ferritin, deposited easily in the reticular endothelial cells. Test dose not required, and low immunogenic potential. We are yet to see. So sometime back, probably a batch of IV iron from one of the companies had an issues, but they were taken off the market. So qualities of FCM are best studied in real life clinical usage across oncology, even the nephrology, even cardiac and the gynecologist. So if you see the free iron, so is much less in the FCM as compared to the other generations of IV iron. So indications and studies in the FCM across indications. So, and if we focus on the anemia and cancer, so one of the studies published in 2021 in the American Journal of Hematology. So that is iron clad study. So which was a phase 3, 18 weeks double blind as compared to placebo.
So 5 minutes.
Yeah. So the primary efficacy endpoint was percentage of patients with decrease in hemoglobin from week 3 to 18, and key secondary efficacy was the change in hemoglobin from base level to week 18. And this showed that percentage of patients who maintained hemoglobin with 0.5 gram per deciliter of baseline from week 3 to 18 was significantly higher with FCM versus placebo. You can see on the left-hand side the curves. The percent with more than 1 gram deciliter increase from baseline was significantly higher, again with FCM 71 versus 54, which was statistically significant. The other study was FIT. So this was oral iron versus FCM in patients pre-surgery for a colorectal cancer patients. So in one arm, 1 to 2 gram of FCM was given intravenously, and in 100 odd patients, 3 tablets of oral ferrous fumarate of ESTGS oral iron was given. You can see on the left-hand side, so patients with hemoglobin normalization, so at day 30 of surgery, which was much higher in case of those who received IV iron. Again, if you see the mean hemoglobin levels for those patients at day 30 receiving IV versus oral was much higher in the IV arm. So anemia and kidney disease. So most of our oncology patients, in 1 out of 3 patients, especially like diseases like multiple myeloma, where anemia is very common. And since India being a hub of diabetics, so we see a CKD patients. So CKD has a comorbidity with cancer. So that's an important kidney disease. So in these patients also now the organ companies have come with from 1 gram. So we had a 500 milligram of FCM and 1000. Now they have come with 750 milligram of IV iron, that is FCM. So 2 doses is good enough. So now the objective of this study, so in the primary efficacy endpoint, mean change to highest hemoglobin.
So 3 minutes.
So now, so you may not give 1 gram. So even 2 doses of 750 milligram is good enough, especially for non-dialysis dependent CKD patient with iron deficiency anemia who is having a cancer. So the cost also comes down, and you also don't overload the patient, because so for a particular patient, if you calculate the iron dose, so 1500 milligram is good enough as a replenishment. So total iron, so just to conclude, so total iron deficiency should be calculated as per weight and baseline hemoglobin. In most patients, it is around 1500 milligram. So even 750 milligram, which is a newly launched. So 2 doses week apart is enough. Iron replacement has key roles in cardiology, oncology, GI disorders, apart from gynecological. So it has moved out of gynecological boxes to now many of our oncology colleagues use IV iron left and right. So it is very, very well demonstrated across large prospective studies in each of the indications, and FCM has been studies all randomized trials in the phase 3s, and many Indian studies are also there with the various amounts of data. So thank you, friends, for a patient sharing, and thank you, Impur, for sponsoring. So back to Dr. Ramila.
Thank you, sir. Very well presented. It's very important. Every day in the OPD we see chemotherapy-induced anemia. So we quickly move towards announcing the quiz winners we already have for this second session. So for question number 1, it is Arun Pachauri. For question number 2, it is Shubham Pandey. Unfortunately, the third question, nobody could answer the pathological type of Mr. Jobs. And for the fourth question, it is Smriti Mahat, if I'm pronouncing her name correctly. And for question number 5, it's Dr. Zarima. So congratulations to all the winners. Big round of applause. And now again over to Dr. Ghanshyam Biswas sir to kindly give the vote of thanks. We come to the end of day 1 now. So over to you, sir.
So we are supposed to be at vote of thanks at 9:20. Just look at your watch. We are at 9.
Yeah. Courtesy.
So courtesy, like, Dr. Romila. So all great clap for Romila. So
no, so not at all.
Master Lee has done a great job. So I'll just salute you. So it's more important to have time based. So I also still recall so Dr. Purvish Parikh sir. So he's very strict. So कोई senior हो कुछ हो कोई मानते नहीं बोले नहीं बंद करने का है तो करने का है. So thank you, Dr. Romila, for all days work. So it has been hectic. So we just so before Garima joins tomorrow for the day 2, we'll have head and neck cancers and gynecological cancers. So tomorrow being Saturday, so we have taken a liberty of half an hour extra. So friends, please join tomorrow for the day 2 of the second oncology update. We'll have the first half for head and neck, followed by gynecological cancers. So it starts from 5:30. You can use the same link, or you can always you'll always get the second link by tonight. And
I think it starts at 5 tomorrow, 5 to 9:30, if I'm not mistaken. Yeah.
5. Sorry, 5. So today was 5:30.
Yeah.
And especially a thanks to Dr. Viraj, so who agreed to the program director, and he has really put together all those abstracts. And thank you, Dr. Saurabh Mishra. So without whom also I could not have completed this day 1, because he's not there on day 2 because he's going to Mumbai. So I'll miss him on day 2. And thank you all speakers, moderators, panelists for a wonderful timings, though we missed few people who agreed for some reasons. So that's always there at any session, so be it a virtual or a physical. So, and I especially thank Sambit, Anita, and many others, so backseat, so who may not be seen on the screen. So their hard work for last 3 months or so. I think so they need a clap. So we have finished on time, and I think everybody have enjoyed. At the peak of time, so there were 201. So even Dr. Amish wrote Khatarnak Dada, it is 201. So it is not seen. So I think so that was so thank you so much.
Thank you, sir.
Ladies and gentlemen. So
catch up with the match going on. I had forgotten about it. I got to remember this some time back. It is like almost 30-70 against India. India's feeble chances of winning, but then they are dropping down wickets on the Australian end. So carry on.
Lost interest after losing the final.
For people, Indians, after all.
So I'm meeting Kapil Dev on 18 December. I'm having So that I am
Sir,
giving.
एक video call करना, मतलब do a video call, make a video call, WhatsApp video call if possible.
He's coming to Bhubaneswar, right? So I'll tell
Oh, wonderful. Thank you.
So it should not be told in the public forum, but telling me. So that's fine. So let's meet tomorrow. So have a restful night and be prepared for tomorrow's marathon again, so that you can have a good sleep on Sunday. Thank you, friends. Take care.
Thank you. Thank you, everyone. Thank you, everyone. Thank you, all the background workers as well. Thank you, sir. Good night. Namaskar.
So Anita, Sambit, you can close down.
Yeah, sure. Thank you, sir. Thank you for your time today.
Thank you, sir. Thank you.
Thank you, Romila ma'am.